Welcome to our conference. I'm excited to dig into some high yield peat stuff today. Last year we had another one of these virtual fall meetings. That was a great meeting on OB topics. So we sort of thought we'd continue working down the life cycle. So all those moms had their babies and now they're kiddos. So we'll learn about taking care of them, which that means next year's conference is going to be ASA 1 20-somethings doing ACL repairs. Thanks to all of you guys for signing in this morning. And especially thanks to our speakers for giving up their morning to help us out. In Bend, looks like outside it's 30 degrees, raining sideways. There's a thick blanket of wildfire smoke. So perfect morning to be inside here, hanging out. I saw Dr. Kirk Lawani. He is on the call. A huge thanks to him for all of his efforts to help organize our speakers. He introduced me to pretty much all of our speakers this morning. I'm just a country doc out here in Bend, Oregon, so my network is not nearly as extensive as his. So thanks, Kirk, for helping us out with arranging our talent this morning. I just wanted to start with a few OSA notes, and I realized I forgot to introduce myself. I'm John Meyer, currently the president of OSA. So we'll just make a few notes this morning on what we've been up to this year, and then we'll get into our topic. First, I want to introduce Shelly. She's on the call. Shelly Shirley, she comes to us from Dalton Advocacy. Dalton has been with us for quite a while now as our partners in lobbying. You guys have heard from Sabrina Riggs, who is our lobbyist from Dalton Advocacy, a number of times. She's done an excellent job, and this year we just expanded Dalton's role with the OSA in taking over our executive director duties for the OSA, and Shelly has been sort of our point of contact with that, and she's done a great job of setting up CME from this meeting and making sure that all of my efforts at sabotaging it were unsuccessful. So thanks, Shelly, for setting this all up this morning. This year, the ASA returned to in-person meetings, so we sent a group to DC for the legislative conference back in May, and next month we're all going to New Orleans. So we have a delegation going to New Orleans for the ASA conference, and when that's over, we'll give you guys an update from any hot topics that come from that. The other thing I wanted to mention, don't forget our Doc Matter platform. You guys should all be signed up for that. That's our sort of communication tool. We launched it during the pandemic, and it's been a great tool to sort of communicate as a group of Oregon anesthesiologists. You should have access to two sites. There's sort of the main OSA site, which is our communication piece, and then you should also have access to the clinical reference site, kind of a decision support tool that Dr. Barry Perlman, one of our board members, he did a fantastic job of setting that up in collaboration with Dr. Mike Aziz of OHSU. So you should have a bunch of resources available there, and feel free to add stuff to that site as you deem appropriate, so that if you'd like to see what other groups are doing and handling clinical situations throughout the state, you can pop on there and check out all of those references. A couple house cleaning notes before we get started. We are getting CME for this meeting. In order to get CME, your attendance has to be verified. So make sure that your name is on the Zoom conference. So if you're calling in on a phone number, I see one phone number up there. Either change your name in the Zoom conference by just clicking on I think for me, there's like, if you hover over your square, there's some 3 dots in the top right corner of your picture or your name, and you can rename yourself. And if you're on a phone and you can't do that, just email Shelly or myself. You can find our contact on the OSA website to make sure that your attendance was verified. The email that Shelly sent out had a course evaluation to fill out. So you'll need to do that to get your CME. Anything else in the process, Shelly, that I'm missing?
No, that's it. That's great. Thank you so much.
Okay, and will we get emailed the certificate, or was the certificate already in the email that was sent?
Once I verify that you attended and I receive your course evaluation, I will email you a certificate.
Okay, cool. Well, thanks for setting it up. Any questions before we get started on OSA questions, ASA questions? And we'll have time at the end as well to discuss any new business. And feel free to email us with things that we can do to sort of better serve you guys as our members. We've been trying to do a few different things these past couple of years since the paradigm shifted a little bit with the pandemic, with that Doc Matter platform, doing these kind of Zoom conference CME meetings. But if there's anything that we as the OSA can do to help you out, feel free to email me or email anybody on the board. And yeah, lots of ways to get involved if you want to be more active in the organization. We've got some new faces going to the ASA conference this year as delegates. And so, yeah, if you'd like to get more involved, email me, or if there's anything we can do for you, also email me or email Shelly and she'll get in touch with me. So if there's no new business with that, let's get going on our presentations this morning. So our first two talks are kind of related, so I thought I'd introduce them together. As Dr. Vavilala, Dr. Eicholtz, and Dr. Muldowney all come to us from Seattle from UW Harborview. And if I'm mispronouncing those names, guys, please let me know. We've been coordinating this through email, so I just know them all as Monica, Maeve, and Pud. But we're happy to have them join us. And then I'm going to introduce Dr. Vavilala first. And hopefully she'll introduce her colleagues for us. And I was looking at her CV yesterday, and before that, I was kind of thinking to myself, man, I've been really busy lately. Seems like there's lots going on. And then I read her CV and I realized that I have like no concept of what the term busy means. She has had a very busy and very energetic history in academics. She started out her education in Houston. She completed a residency in pediatrics, and then she completed a residency at UW in anesthesia, and she's been on faculty there since 1997. During that time, she's been unbelievably active in education and research. Among many, many things, she's the director of the UW Harborview Injury Prevention and Research Center. She's involved in many different community initiatives to essentially keep the public safe. She's been invited to speak pretty much everywhere that I can see. And what struck me most about her path is just how incredibly collaborative it has been. Everything I see on her CV seems to be, she's involved in, from what looks like all of the academic departments at UW, and a lot of her academic interests have been with stakeholders in the community and pretty much every specialty you can think of. So I'm really excited for her talk this morning. But before we begin, I think she's second on our list. Monica, would you mind introducing your colleagues as well?
Absolutely. So thank you before we begin to you and to the Oregon Society of Anesthesiologists for inviting us to be here today. We're neighbors, and so it's a wonderful opportunity to get to know you and to share with you some of our thoughts on these subjects. And thank you for that very warm introduction. I appreciate that. So when you asked me to give a talk, I thought, what a wonderful opportunity it is for us at UW to share with you the work of our faculty, our junior faculty, and to help promote them across the region. And so I've asked Dr. Eichholz and Dr. Muldowney to join in this session this morning. So they're wonderful colleagues at Harborview Medical Center. Dr. Eichholz is UW Acting Assistant Professor of Anesthesiology and Pain Medicine. And she earned her degree, her medical degree, and completed her anesthesiology residency training at Chulalongkorn University in Bangkok, Thailand. She then came to us and completed a trauma anesthesia fellowship. And it was really clear to us then that she would really love it if she decided to come join us on faculty. She's done that and is focusing her research and her clinical expertise in the area of trauma resuscitation, perioperative transfusion, and airway management. And I'm really thrilled that she's agreed to join this panel this morning. Dr. Maeve Muldowney is also UW Acting Assistant Professor of Anesthesiology and Pain Medicine. And in many ways, it's wonderful to have both of them collaborate with each other in related areas, because that idea of teamwork and team science and team productivity is really important. Dr. Muldowney earned her medical degree from the Medical School University of Dublin in Ireland, and completed her residency, College of Anesthesiology in Ireland as well. And again, really wonderful to have her join us on faculty. Her interests include hemostatic resuscitation and trauma and regional anesthesia. And with that, I think we're supposed to start at 9:15, so we're on time. And thank you to Drs. Muldowney and Eichholz for taking this away and for representing the UW.
I will start my part here. Can everyone see the share screen okay?
Good morning, everyone. It is such a pleasure to be here starting off this meeting. I hope everyone is having a good day wherever you are. My name is Putkrong Eichholz. I work at Harborview Medical Center, University of Washington. And we will have Dr. Maeve Muldowney, a wonderful colleague of mine from the same institute, presenting after. The topic today is blood transfusion in pediatric trauma. I want to start by declaring that neither of us have any conflict of interest regarding this lecture. Overall, today we'll be talking about epidemiology of pediatric trauma, with the stress on differences in children's physiological response to bleeding. We will also discuss resuscitation strategies, including access, crystalloid, massive transfusion, whole blood use, tranexamic acid, and viscoelastic testings. Injuries are the #1 mortality cause for children and young adults in the United States. According to the CDC, even though the numbers are decreasing, injuries still account for almost 7,000 deaths of children and young adults per year. This is almost 1 child every hour. Death rates are highest in male of all age, in infants and adolescents, especially prevalent in rural areas, and among Black and American Indian children. The most common causes you can see here is motor vehicle accident, although this is changing, as we will see in the upcoming slide. Here is a graph from Johns Hopkins showing children's mortality from motor vehicle accident from 2005 to 2017. You can appreciate that the overall numbers are decreasing, dropping down each year due to better car safety features and road safety regulations. However, in the same time frame, mortality rate has increased about 10% amongst Black children. For non-fatal injuries, fall, other blunt injuries, and burns are among the most common mechanisms of injury in this age group. From all the causes we saw before, we can gather that most pediatric injuries will be blunt of nature. Also, the rate of traumatic brain injury is very high in this age group and can reach up to 80% of all injury. And because of their smaller bodies, we often see multi-system injuries in these patients. With that said, there is a trend starting from 2017 of increasing firearms injuries among children and young adults in the United States. And the fatality from this has actually in 2017 exceeded that of a car accident. So cars are getting safer, while the same cannot be said for guns. Moving on to some points about differences in pediatric physiology, starting with the cardiovascular system. Children in general have higher oxygen requirement and thus need higher cardiac output per weight. But because their myocardium is less mature and the coupling between small subunits are less developed, they can only slightly increase their cardiac output with increased preload. Also, the heart is less tolerant of increased afterload. So mainly pediatric cardiac output is very heart rate dependent, and contractility is also dependent on calcium. Another point that we are all aware of taking care of children is their predominance of parasympathetic system and the tendency to go into bradycardia. Also, in general, children are less responsive to exogenous catecholamine and might need higher dosage per weight. Another important point is that pediatric patients respond to hypovolemia quite differently than adults. In adults, usually increasing degree of hypovolemia will result in increasing in heart rate and narrowing of pulse pressure. Then you'll start seeing a drop in blood pressure from around 25 to 30% of blood loss onwards. For children, since their cardiac output is very heart rate dependent, most often we'll see compensatory high to very high heart rate with relatively stable blood pressure. A drop in the blood pressure will only be apparent when blood loss is very severe. To reiterate, here on the x-axis is degree of blood loss or hypovolemia. Notice that the purple curve, the cardiac output here, is relatively maintained up to about 25% of blood lost. After that, cardiac output start dropping, but because of compensatory rise in the SVR and the heart rate, blood pressure is relatively maintained, and not until around 40% of hypovolemia do we start seeing hypertension occurring in children. To detect hypotension, we have to know the normal range of blood pressure in each age group. Two easy formulas in children of more than 1 year old you can use are at 50th percentile or the median. Systolic blood pressure is usually 90 plus age times 2. And at around 5th percentile, that number is 70 plus age times 2. I personally use the lower formula as the minimal systolic blood pressure curve for children during general anesthesia. Other important physiological differences I want to point out involve the hematologic system. In general, children coagulation factors are less developed. Many factors are reduced in number, while many have reduced functionality. However, since their coagulation inhibition are also less developed, the end result is usually balanced hemostasis. However, if you measure coagulogram separately, then the numbers can be misleadingly prolonged. Infants also have higher hematocrit and carry a different type of hemoglobin, hemoglobin F, which has more affinity to oxygen than hemoglobin A. Due to their reduced ability to form thrombin, especially in younger children, we see very low incidence of venous thromboembolism in children, and they rarely need thromboembolism prophylaxis. Another important point that we use regularly in our clinical practice is the amount of blood or total blood volume in each age group. In general, I suggest remembering the lower numbers because that means threshold for triggering blood transfusion will be earlier. So that means 90 milliliter per kilo for preterm, 80 milliliter per kilo for term infants, 75 for infant, and 70 milliliter per kilo for children. Now moving on to resuscitation strategy. I will only be talking about venous access, crystalloid use, and massive transfusion, then I will hand over to Dr. Maldowney. For venous access, as we are all aware, the bigger the cannula, the faster the rate. This table here shows the flow rate of intravenous fluid according to the cannula sizes. The second and third columns show flow rate when used in conjunction with rapid infuser. General recommendations in pediatric trauma is at least 220 gauge IVs for resuscitation. Also, the Advanced Trauma Life Support or the ATLS recommends sequence of obtaining access as shown here. Usually, attempt will be made to start peripheral IVs. If that is not achievable within a couple of minutes, then intra-arches or IO access is recommended. And the most common sites are anteromedial tibia, then onto the contralateral tibia, and then distal femur. The usual size of IO cannula for children of more than 1 year is 15 gauge. Obviously, if there is any fractures or failed IO attempts on the ipsilateral site, then it is contraindicated. If IO is not possible or not successful, then central venous access and venous cut down can be considered sequentially. Initial fluid for resuscitation of both adults and pediatric trauma is still warmed isotonic crystalloid, but as we are all aware, the recommendation is to limit crystalloid administration to reduce the dilution effect and the subsequent hypocoagulation. For children, it is recommended to start with 20 milliliter per kilo of warmed isotonic crystalloid infusion. This can be repeated up to 3 times, but if blood products can be obtained earlier, then 1 to 2 boluses should suffice. As there is evidence in pediatric trauma that increased crystalloid, especially when it's more than 60 milliliter per kilo, is associated with increased transfusion requirement, increased length of hospital stay, and a tendency towards increased mortality. So after 20 to 40 milliliter per kilo of crystalloid, then 10 to 20 milliliter per kilo of either packed red cells or whole blood is recommended. The optimum ratio of blood component therapy will be discussed in the upcoming slides. To guide the success of resuscitation, a few clinical signs are valuable, such as slowing of tachycardia, skin warmth, and urine output. In adults, if you all remember, by definition, massive transfusion is transfusion of more than 10 units of packed red blood cells in 24 hours. Of course, this number cannot be used in children given that a unit of PRBC will be approximately the whole of a blood volume in a 4 kilogram infant already. So for children, the amount is usually defined per body weight or blood volume. Similar to adults, there are many ways to define massive transfusion in children as listed here, like replacing 1 blood volume in 24 hours, half blood volume in 3 hours, or 10% of their blood volume a minute. So for example, in a 10 kilogram child, if you give more than 70 milliliter of blood or 7 pushes of a 10 milliliter syringe in a minute, that counts as massive transfusion already. But the most common definition of massive transfusion used in literature for children is usually more than 40 milliliter per kilo of any blood product in 24 hours. This is because a number of studies found an acute increase in mortality at this cut point. Another topic of interest is what should we use as triggering criteria for massive transfusion? For adults, there are some validated tools such as the ABC score that show good sensitivity and specificity for massive transfusion. For children, these criteria are less well defined. However, a few studies explore this question. One retrospective observational study of about 200 traumatized children found that if a child meet 2 of the 3 criteria listed here, so either base deficit from venous blood of 6.9 or less, INR of more than 1.4, or elevated shock index, pediatric age adjust, shortened as SIPA score. If 2 of these 3 are met, then there is a good sensitivity of predicting massive transfusion. However, the specificity of these criteria are quite low, as you can see. This number shows the threshold for shock index according to each age group. Shock index is calculated by dividing heart rate with systolic blood pressure. And we consider shock index to be elevated when the number is more than 1.2 in younger children and more than 1 in older children. On to the next famous question. What is the optimum ratio for blood transfusion? The data to answer this specific question in traumatized pediatric is very limited. Most of the recommendations are based on extrapolated evidence from adults. In children, there are about 6 retrospective and 1 prospective observational study and no randomized trial trying to answer this question. Most studies showed improved survival in children who received high ratio of plasma to packed red blood cells. However, the definition of high is less universal. Some use less than 2:1 as high, and some used 1:1 as high. We'll talk about a few of these studies in the upcoming slides. The first study was done by Dr. Vavillara and other colleagues at our center. This is a large retrospective study of over 500 traumatized children requiring massive transfusion. The main objective was to determine if ratio of plasma and platelets to red cells was associated with mortality. Median age in this study was 5 and 75% was blunt trauma. After multivariable regression analysis, they found that, as shown in this table, that children who received plasma to red cells ratio of 2:1 or less, and especially in the 1:1 group, has improved survival at both 4 and 24 hours compared to children who received lower ratio of plasma. However, the platelets to RBC ratios was not associated with improved survival. For secondary outcomes, the group also found statistical significance in reduction in in-hospital mortality in higher FFP to red cells group, and again, no difference in the platelets group. Of note, they are also found increased risk of deep vein thrombosis in higher FFP group. Another study we'll talk about here is the prospective observational study of close to 200 bleeding pediatric patients. The median age here is higher at 10-year-old and about 60% was blunt trauma. High ratio of plasma to PRBC here is defined as less than 2:1 PRBC to FFP. The Kaplan-Meier curve on the left here shows that high plasma group has increased survival at both 6 and 24 hours. The group also found that for every 10 milliliter per kilo of plasma that lagged behind the volume of red blood cells, there is about 20% increase of mortality odds. not shown here but similar to the previous study. They did not find association between high platelets group and improved survival. And as one of their secondary outcomes, the group found that the rate of ARDS was higher among children with high plasma ratio. Another retrospective study of about 100 patients also shows similar results of reduced mortality in higher FFP ratio group, especially in the 1-to-1 group. After adjustment for age, injury severity, and Glasgow Coma Scale score, they found that the odds of mortalities increased by around threefold for every additional unit of red blood cells that went above 1-to-1 ratio. With all the above evidence, the latest guideline from the Transfusion and Anemia Expertise Initiative Control Avoidance of Bleeding, or the TAXI-CAP group, published earlier this year and also summarized in August edition of Anesthesia and Analgesia, recommends transfusion in ratio of 1-to-1-to-1 of red blood cells to plasma to platelets in critically ill children with severe bleeding. And severe bleeding in this case is defined as bleeding that results in one or more organ dysfunction that leads to more than 20% decrease of blood pressure or 20% increase in heart rate, or with more than 20% drop in hematocrit, or more than 5 milliliter per kilo per hour of bleeding for longer than 1 hour. Moving on to complications of massive transfusion. Most common complications of massive transfusion event, regardless of age, are metabolic disturbances. Given the time limitation, we will only be talking about two immediate complications that we see most commonly in the operating room, and that can cause severe consequences. The most common one is hypocalcemia. All of us are aware of citrate toxicity that comes with given blood. However, it is less well known that fresh frozen plasma has the highest concentration of citrate per unit volume of any blood products, thus most likely to cause hypocalcemia. As shown here in this graph, transfusion of plasma above the rate of 1 milliliter per kilo per minute will result in hypocalcemia, and this can be quite severe. To put into perspective, this is just 10 milliliter syringe of FFP in a 10 kilogram child. As you can see in this graph, if no more blood product is given, then this hypocalcemia will get corrected as the liver metabolizes the citrate. However, in traumatized children, where hepatic blood flow is usually impaired, citrate will be less likely to get metabolized, and these children will most likely need exogenous calcium therapy. The second most common cause of electrolyte disturbance in massive transfusion is hyperkalemia, and that is the reason why most blood banks will preferentially release fresher or newer blood for pediatric patients. To summarize, before I hand over to Dr. Maldowney, in traumatized children, there are a number of useful criteria for triggering massive transfusion, such as base deficit, INR, and shock index. Transfusion of blood products is recommended at 1-to-1-to-1 and at the very least 2-to-1-to-1. Labs should be taken every 30 to 60 minutes to keep goals as follow. Calcium supplement should be given, if using calcium chloride, then approximately 5 to 10 milligram per kilo for every 20 milliliter per kilo of blood product given is recommended. Goals at the end of massive transfusion are less clearly described in literature, but my suggestion here is at least hemoglobin should be 8, INR should be less than 1.5, Platelets should be more than 75,000 and fibrinogen should be more than 100. Some guidelines, such as the 2019 European one, suggest even higher at 150 for fibrinogen. And lastly, here are some rough estimates of increase in each component after certain doses of blood product.
Okay. So following on from Dr. Ackholz's talk, I'm going to speak about some specific considerations in pediatric transfusion. And so I'm going to speak about goal-directed transfusion strategies and the use of whole blood in pediatric patients, and then antifibrinolytic therapy as a hemostatic adjunct in transfusion. So as Dr. Ackholz spoke about, we initially start hemostatic resuscitation in empiric ratios, something approaching 1:1:1. And then as the scenario evolves, we typically switch towards a more individualized goal-directed strategy. And there are two ways to achieve that, to individualize therapy towards a patient and identify their specific coagulation deficits. The first being conventional coagulation testing, or also the use of viscoelastic testing. And so thromboelastography and thromboelastometry are both methods that assess the strength of clot formation, clot initiation, clot degradation in a sample of whole blood. And then the timing and the shape of the curve give a clue as to specific hemostatic deficits, and then that can help guide what blood product is most appropriate for that patient. And while this is not meant to be an exhaustive talk on thromboelastography. As example, if we look at the OR time, which is the time towards clot initiation and clot formation, if this is prolonged, then that suggests that there may be a deficit of coagulation factors. And so then fresh frozen plasma will be the most appropriate blood product to administer. And the use of both TEG and ROTEM is making its way into massive transfusion protocols. So this is an example of a massive transfusion protocol that incorporates both conventional or standard laboratory testing and ROTEM results. And so you can see in the boxes that for a given ROTEM result, it suggests what kind of hemostatic product should be given. And so there's advantages and disadvantages to both viscoelastic testing or standard laboratory testing. Depending on your institution, viscoelastic testing may be more rapid or maybe slower than getting back conventional coagulation testing from your laboratory. Also, viscoelastic testing was developed with adults in mind, and so its reference ranges pertain to adult whole blood. And while most authors on this topic would say that it's still applicable to children over the age of 1, in infants under that age who have physiologically less antithrombin and protein C and protein S, then their TEG may be misinterpreted by someone who doesn't have considerable experience in analyzing TEG or ROTEM results for that patient population. So as it stands, we don't have any good and prospective evidence about which is superior to guide transfusion protocols. Systematic analysis and Cochrane database reviews on this topic both say that viscoelastic testing may be beneficial, but there's so much heterogeneity in the studies examined and a high risk of bias that it's difficult to make any firm conclusions on which is superior. So moving on to whole blood. So whole blood is a blood component that contains all blood components in a single unit versus giving them separately in a 1:1:1 ratio. And whole blood is a more concentrated unit because it contains less additive solution and less anticoagulant than giving the same components in 3 individualized bags. And so a complication of massive transfusion is that while we seek to avoid hemodilution and worsening coagulopathy, the volume of additive solutions and anticoagulant that's administered as we give products in 1:1:1 ratios can be high. And so we can contribute towards hemodilution, though it's the problem we're trying to fix. And so some suggestion that whole blood may be superior in that regard because we may be able to provide even superior quantities of clotting factors and platelets and a more concentrated hematocrit product and give less anticoagulant and less additive solution. So at Harborview, we do use whole blood in resuscitation of children and adolescents, and it is available for use for this group. It's low titer O whole blood, so the same supply that we use for our adult trauma patients. And there are some intuitive advantages towards using whole blood. It can reduce the time towards receiving all blood components versus giving them 1:1:1 in series. Also, it's 1 product versus 3 each time. And so in a potentially very stressful environment, that means that there's less checking of blood and less scanning of blood product. And so there can be people freed up for more critical tasks when we're giving less number of units. Also pertinent to children, they would be exposed towards fewer donors when you're using whole blood because it's all derived from a single donor versus giving those blood components separately, which could all come from individual donors. And so perhaps less risk of sensitization. And then, as I mentioned previously, a unit of whole blood will contain less additive and less anticoagulant versus giving those components separately. And so perhaps it would be a more superior hemostatic product. So we do have some prospective evidence about the use of whole blood in trauma. This small study suggested that there was no increase in adverse events versus the use of component therapy. And so certainly comparatively, whole blood doesn't seem to cause any more complications in transfusion than our standard component therapy. This was an analysis of the Trauma and Quality Improvement Project. And so these authors looked at 135 children that were resuscitated with whole blood in addition to component therapy and matched those towards patients who just received component therapy. And the authors suggest that patients who received whole blood as part of their resuscitation actually required less overall transfusion at 4 hours and 24 hours versus those that just received component therapy. And so perhaps some retrospective evidence, at least, that whole blood may be superior hemostatic product. Right now, UW is involved in enrolling adults into a study looking at the pre-hospital use of whole blood. And there is a pediatric study that will come online, but it's still in the very early pre-funding stages. And so it's probably going to be some time before we have any robust prospective data about whole blood use in pediatric patients. So moving on towards antifibrinolytic therapy. Antifibrinolytic therapies like tranexamic acid and aminocaproic acid are both found to be very safe and very efficacious for use in pediatric elective surgery where large blood loss is anticipated. So like large cardiac surgery, scoliosis surgery, or craniofacial procedures, the use of an antifibrinolytic has been shown to reduce overall blood loss and subsequently the need for blood transfusion. And looking at both of these medications, they've both been shown to have excellent safety profiles. Because TXA is the most widely used in trauma, then I'm going to focus specifically on TXA. But in these studies for elective surgical cases, there's a huge variation in dosing. So anywhere from 10 milligrams per kilo to 100 milligrams per kilo as a bolus dose. And so at the higher end of that spectrum, that's much, much higher than what we would use in trauma. So a recap on the mechanism of action of TXA. It's a lysine analog that binds to plasminogen and so stops its formation to plasmin and so therefore stops the degradation of fibrin, and so helps to stabilize clot. And so we do, again, have some retrospective data of the use of TXA in bleeding. So these authors actually looked at all antifibrinolytics, and they also looked at children who were bleeding for any reason, so not specifically to trauma, but both for medical, surgical, and traumatic hemorrhage. And so children who received an antifibrinolytic therapy overall had a lower 6 and 24-hour mortality versus those who were not treated with an antifibrinolytic therapy. So there's evidence that the use of an antifibrinolytic therapy has a survival benefit. A second study that is more specific to the trauma population is the PTRAC study. And this was a retrospective study that looked at pediatric admissions to a military hospital over a 4-year period. And so there were 766 admissions over this time period. And you can see overall the number of patients who received TXA was small, about 66 patients in total. And they were treated using an adult TXA protocol, so a 1 gram bolus dose. And the authors of this study were looking to see if those who received TXA had a survival benefit versus those who did not. And so this is one of their findings. Looking at the impact of TXA on mortality, you can see that the patients who were the most severely injured, so those with injury severity scores greater than 15, did not reach statistically significant improved survival, but there certainly was a trend that favored the use of TXA in improving survival in these patients. And then the last study on TXA in trauma that I'm going to mention is the TikTok trial. And so we only have, at this point, the feasibility study published. And it's actually worth a read because it gives some good insight into the difficulties of conducting a prospective trial in pediatric trauma with a time-critical medication has to be given in quite a small window. And so only the initial feasibility study is available. It examined 2 different TXA transfusion strategies, a 15 milligram per kilo initial dose versus a 30 milligram per kilo loading dose versus a saline placebo. And of course, in this study, they didn't find any difference, but of course it wasn't powered to because it's just the initial feasibility study. And so they hope to recruit 2,000 patients over a 4-year period. And so again, it'll be some number of years before we have any specific prospective evidence available, but it should be coming on board. So in summary, with regards to TXA use in pediatric trauma, we don't have any robust evidence to make any definitive guidelines right now. But we do have a lot of evidence that should suggest that TXA use is safe in children. And so those at risk of life-threatening hemorrhage may benefit from the use of TXA. Similar to adults, it's recommended it's given as early as possible, certainly within a 3-hour window, but as soon as feasible, it should be administered. And it is in our Harborview Medical Center algorithm for the management of hemorrhage in children. So we recommend a 15 milligram per kilo loading dose and a 2 milligram per kilo hour maintenance rate. And it can be given intravenous or interosseous. And so its administration shouldn't be delayed while you're waiting for IV access. So there is a lot of obviously a lot of information on this slide. This is the Harborview Medical Center protocol for transfusion, and it's available from the Washington Department of Health website, so you can familiarize yourself with it in your own time. But there are a few points on this that I'd like to highlight. So the first is that children over the age of 12 are treated similar to adults, and so whatever your normal protocol for the use of adults in massive transfusion is, it can be applied to children over the age of 12. Younger than that age, children are transfused according to their Breslow color chart. And so you'll see on this chart that the actual volume of blood product to be administered has already been calculated. And so it can take some of the cognitive load off you when you're in that situation. And then the last point I'd like to highlight is that children less than 4 months of age should receive irradiated blood. And this is because they have an immature immune system. And so they are at risk of transfusion-associated immunomodulation if given non-irradiated products. And so it's a special caveat for the very youngest of children. So where does our talk fit into in the overriding principles of damage control resuscitation? And so we spoke about minimizing the use of crystalloid in resuscitation, and also goals and methods of hemostatic resuscitation. And these are two important tenets of damage control resuscitation that go hand in hand with other aspects of damage control resuscitation. So early bleeding control, where long bone fractures are splinted, tourniquets are applied if indicated, pressure is applied to any junctional hemorrhage or any bleeding points. Also keeping the child warm because children are at higher risk of heat loss because of their large surface area to body mass ratio. And so keeping them warm is another important part of damage control resuscitation. And then, of course, damage control surgery for controlling contamination and also for controlling hemorrhage. Where the principles of DCR differ somewhat in pediatric patients is in the area of permissive hypotension. And so permissive hypotension is a strategy that can be employed in adult damage control resuscitation, where uncontrolled hemorrhage is ongoing. Then you may tolerate a lower systolic blood pressure and hold off on fluid resuscitation until some kind of hemorrhage control can be achieved. And so this is to not cause hemodilution and to not disrupt clot. But in children, it's not recommended as a strategy to pursue. As Dr. Ackles spoke about, hypotension in children is generally a very, very late sign of hypovolemia and hemorrhagic shock. And so those children, and that could be a pre-terminal event for some of those children. And so it should never be pursued as a strategy in children. Also, children are more at risk of having a multi-compartment trauma because of their small body size. And so concomitant TBI would be relatively more common in children. And so there's evidence that tolerating lower blood pressures in children may worsen their prognosis in traumatic brain injury. And also children live closer towards their lower limit of normal in cerebral autoregulation. And so again, tolerating lower blood pressure may cause critical hypoperfusion of their brains. And so permissive hypotension is not recommended as a strategy in damage control resuscitation of children. So to summarize, as it stands, viscoelastic testing has not been shown to have any mortality benefit versus conventional coagulation testing in children. And so we're still awaiting evidence about if one method is superior to the other. Whole blood is a feasible blood product to give to pediatric trauma patients. There's evidence that suggests that it does not have any increase in adverse events versus giving component therapy. And in fact, it may be beneficial because it may overall reduce the transfusion requirements that children have, and it exposes children to less donors versus using individual components. And then lastly, with regard to tranexamic acid, its safety has been well established in other areas of pediatric surgery. However, its efficacy in trauma is still under review. And so also too under review is the optimum dosing. There's been a wide variation in dosing described in pediatrics, but specifically to trauma, it's not yet known what the optimum dosing strategy is. And so we'd like to thank Dr. Vavilala and Dr. Hess for their review and assistance with the content in this lecture. And we have time to take questions.
Looks like there were a couple that popped up in the chat bar. One being, is there any utility, any use for prothrombin complex concentrates or Riostat, the fibrinogen concentrates in peds?
I can answer this one. So I would say for both
for PPC and also fibrinogen concentrate, the evidence is not, we don't have enough evidence to answer specifically for pediatric population. But if we include the adult population, there are some studies, and I would try to answer this in accordance to Dr. Muldowney's slides that kind of separated the resuscitation phase into the initial one where we do mostly ratio based, and the later point where we do kind of goal directed. So for fibrinogen concentrate, the initial resuscitation where we do 1-to-1-to-1, that's one strategy. And fibrinogen concentrate is, I think I would say, more popular in for the European resuscitation guideline. And they also describe as an alternative to 1-to-1-to-1 to use just PRBCs in conjunction with fibrinogen. And their recommended dose is about 2 grams of fibrinogen concentrate per 4 units of PRBC, given as initial resuscitation kind of package. For a later point of resuscitation, the goal-directed point, then usually we will check for either Klaus fibrinogen level, and if it's reduced, the goal is usually below, if it's below 200, if it's below 100 or 150, then we give fibrinogen concentrate. Or if we used viscoelastic test, and if, for example, in ROTEM, if the FibTem is reduced in amplitudes, then fibrinogen is given. For prothrombin complex concentrate, the initial use is usually when we know that the patient is anticoagulated, either from warfarin or direct oral anticoagulant. Then prothrombin concentrate can be given upfront, but later on it can be used instead of plasma in groups that have reduced clot initiation. So maybe prolonged clotting time on viscoelastic test.
Thank you. And then the other question that popped up is kind of in relation to the TXA data. Do you find the same thing with Amicar?
So the secondary analysis that I had shown on one of my slides actually was reviewing analysis of pediatric patients that received any antifibrinolytic. So there was both TXA and aminocaproic acid included in that study. And that had shown that there was or conferred a survival advantage to the use of any antifibrinolytic. I think the focus on TXA in pediatric literature is because that has been the focus in adult literature. And so, because a lot of our pediatric guidelines come from extrapolation of adult data, because we simply don't have enough study or evidence to make those kind of assessments directly from pediatrics. And so we just apply a lot of our adult literature. And so I think because TXA has been so widely used, like the CRASH-2 trial that had over 20,000 enrollments, and then subsequently CRASH-3, that's why the focus on an anti-TXA as the antifibrinolytic of choice has emerged. So it's not to say that the use of aminocaproic acid won't work. I think it's just that we've applied what we've learned from adults to kids, and so TXA has become the focus. But from that analysis that I mentioned, that was children who were bleeding from any cause, and so some of them did receive aminocaproic acid instead.
Great. Any other questions out there? Well, thanks, Dr. Eichholz and Dr. Muldowney. That was outstanding. Thank
you.
And I think we'll move on to Dr. Vavilala next and continue our pair of topics on trauma. Let's see, Dr. Vavalel, you might still be muted.
That's not helpful. Okay, great. Well, thank you. Can everyone see my slides? Visible? Yes, okay, great. Well, thank you again. And so I think this presentation is a nice extension of what Drs. Muldowney and Eichholz have just presented. So talking about pediatric traumatic brain injury, specifically focusing on guidelines. So I've spent the last 25 years of my career trying to understand how to, define what our quality of care metrics should be, and trying to understand how TBI affects the care that we give, and try to figure out what types of care should we be providing. So I want to start off by talking about national priorities in TBI care and research, and then I'll talk about the Brain Trauma Foundation guidelines in severe pediatric traumatic brain injury, and conclude by discussing some anesthetic implications for the care of children and infants and adolescents with severe pediatric TBI. So this presentation is focused on severe TBI. There are some specifics we can talk about in the discussion section if you're interested in talking about mild and moderate traumatic brain injury. So the TBI burden is really quite big. And, I would say that pediatric trauma is often not front of mind for folks who are taking care of injured patients overall, because children constitute less number, but proportionately, traumatic brain injury and trauma are a leading cause of death for children and adolescents. And so a large number of our patients will be seen in the emergency departments, be hospitalized, and die from TBI. On the adult side, the military service members have been afflicted with TBI significantly. And so across the lifespan, the TBI burden is quite large. And if you have a child with traumatic brain injury, you're going to likely struggle with keeping your job, trying to figure out how to educate and school them. And this is going to cause significant stress for the family. And so given the paucity of inpatient rehabilitation units across the country and even outpatient rehab facilities, only 13 to 25% of patients with moderate or severe TBI actually receive rehabilitation care. So it's a big problem, and we're estimating around $750 billion for about 2 million people who experience traumatic brain injury every year. So a huge cost burden as well, in addition to it being a burden for patients and families. So I was fortunate this year to be invited by the National Academies of Sciences, Engineering, and Medicine to participate in an 18-member TBI care and research task force, where we held public workshops, participated in conversations with policymakers and community members and patients and families to understand how we can move the needle on this. And we were tasked to develop a report that identifies major barriers and knowledge gaps that are impeding progress, highlighting opportunities for collaborative action, and to provide a roadmap to help guide the field forward. So there are some key messages that we reported in this report that is publicly available. And here they are. So recognizing that TBI is not an isolated acute event, that it needs to be managed as a condition that's influenced by biological, psychosocial, and socioecological factors that have long-term effects, that we need an updated and more precise TBI classification system. So I think what you'll see over the next few years is that we will start to move away from the Glasgow Coma Scale score, something we learned very integral to how we assess neurological status in traumatic brain injury. The US really lacks a comprehensive framework for addressing TBI across the continuum of care, and we recommended that an effective learning health system and system in general is needed to anticipate, respond, and learn in a coordinated fashion. And so having said that, there has been progress made to some degree, and I'd like to share that with you. So central to this is our understanding that there are stages of a care journey after TBI, and you can make such a concept map for any condition that you're really starting to think about. So first is recognizing we actually have a large number of patients, children and adolescents and adults in whom we have no idea that there's a TBI, because the less severe it is, they come to our anesthesiology practice, they come for surgery, and we focus on the procedure and the case, but we, particularly if an ICP monitor is not in place, we don't really pay that much attention to the brain in our clinical practice. And I think this is a problem because the TBI comes with a certain set of, I would say, abnormalities biochemically, physiologically, and those things could worsen if we don't pay attention to prevention of second insults and we don't practice evidence-based TBI care. So this in the acute care setting is really important. Handoffs between pre-hospital care, operating room personnel, ICU teams, to really figure out how to minimize second insults. And I'll spend most of the presentation talking about the acute care period. So as I mentioned, the classification scheme, so somebody comes in with a GCS of 14 or 13, we're often reassured that it's not a problem. In fact, it could be because that patient who has a moderate or mild TBI or has a GCS of 11, and you say they have a moderate TBI, could deteriorate. And this happens quite a bit in our hospitals, and we just don't know because we don't track the deterioration as well as we do assess patients who come in with a category of TBI called severe or mild or moderate. And then as I presented, the rehab facility is really a challenge and is follow-up because these patients actually don't get good follow-up, don't recover well, or reintegrate into society. And for many, the journey is neither smooth nor continuous, and they develop chronic conditions, psychosocial conditions, anxiety, stress disorders, and we know mental health is a big issue exacerbated by the COVID-19 pandemic. And we're learning a lot about the relationship between TBI and suicide, and this is a big problem. So if you're re-injured, that compounds the situation and you start this cycle all over again. So I know we're, usually in the care of these patients for maybe 2 hours or 3 hours or an hour, depending on the procedures that they undergo, but this is a critical time for us to actually provide stabilization. So this report created a set of 8 recommendations that are very broad and overarching. And where I contributed as an anesthesiologist is really trying to think about acute care and how do we reduce unwarranted variability and gaps, and to provide clinical care guidelines so that we actually provide the best known care that we can. So those of you who are interested in learning more about this report is publicly available for free, and it is on the internet. So if you just type in TBI Roadmap Accelerating, you'll find it, and there are a lot of details in here. About unwanted variability. So there's a need for guidelines, and there's a need for anesthesiology guidelines because we want to reduce this unwanted variability in care. We want to achieve acceptable care provision to provide care where evidence suggests we should provide care, and we want to facilitate good practice. So focusing now on severe pediatric TBI, there have been guidelines published, first in 2003, then in 2012, and in 2019. And I participated in the development of these national level pediatric TBI guidelines the last 2 rounds. And it's interesting, this was sponsored by the Brain Trauma Foundation, and we really tried to include evidence where there was, but it's not perfect. So there's a lot of changes between the iterations of the guidelines. For example, we kept recommendations where we thought there was quality of evidence that suggested it. We got rid of topics where we thought that there were weak recommendations. And so while that's good because it suggests learning, the downside of it is that certain topics were dropped completely. And one topic that was dropped for lack of evidence was the pre-hospital, or really talking about hypotension in regards to systolic blood pressure targets. And as Dr. Muldowney Dr. Eichholz mentioned actually earlier, the ATLS guidelines of looking at 70 plus 2 times the age as the minimum blood pressure target. That's actually quite low. And that is because the brain looks at mean arterial pressure and not systolic pressure. Data that we've generated since then suggests that the systolic blood pressure target should probably 50th percentile for age. The challenge with that is that we don't think that way as practitioners. And so I think there's still a lot of work to be done to try to figure out what the optimal blood pressure targets should be. Did I get cut off somewhere, and should I restart earlier, or are we good?
You can restart from where you just were. I'm not sure what happened. Your presentation closed.
Ah, okay. Can you see my slides, or is it not visible?
Not visible right now.
Okay. How about this? Is it back?
Yes.
Okay, and did I lose everyone?
I would start again from this slide.
Okay, terrific. Thank you. So the Brain Trauma Foundation guidelines from 2019. I'll talk a little bit about what are the topics that are included, because I think these are the most recent. 3 of the topics address monitoring, so ICP, advanced neuromonitoring, and neuroimaging. 2 address thresholds, and there are a number of recommendations related to treatments, and I'll spend some time talking about these. So when we think about following guidelines, it's important to keep in mind how guidelines were derived. So just to share with you that we included literature that was generated from patients who were 0 to 18 years, who had traumatic brain injury and who had an admission GCS of less than 9. We excluded studies where greater than 15% of the patient population did not include children. And we excluded non-traumatic brain injuries like subarachnoid hemorrhage and arteriovenous malformations. We excluded articles that included neonatal newborn birth injuries because we didn't think that was the intent of the guidelines here. So we included studies that addressed mortality, neurological function, in-hospital data, and studies that were derived from randomized controlled trials, cohort studies, case control studies, and treatment series. So our initial review was conducted by with folks who had methodological expertise. We then met to review these articles and then signed off on the final documents that were included. And the process that we used, so the level of recommendations are level 1, if they're based on high quality body of evidence, level 2, if it's based on moderate quality, level 3 on low quality. And if we were not able to make a recommendation because there just were no studies, we said so. And the quality of studies, in addition to the level, we also, talked about, are these class 1, class 2, or in class 3? So the classification was tied to our level of recommendation. So if we had good quality RCTs, we said those were class 1. If they were moderate quality or good quality observational studies, we designated those as class 2, and poor quality RCTs were class 3. So we may have made recommendations, but it's also important for us to understand that those recommendations were derived based on quality of evidence. So for ICP monitoring, there's been a lot of discussion about whether or not ICP monitoring actually benefits patients. And a New England Journal article from adults would show that if you have good neurocritical care, you may not need ICP monitors per se. From the data that we looked at for severe TBI in children, we made a level 3 recommendation that it improves overall outcomes. And so at the level 3, criteria, use of ICP monitoring is suggested. And so there was no change in this recommendation from prior iterations of the guidelines. In terms of advanced neuromonitoring, now recognizing that brain tissue oxygen and monitoring is really not used clinically. It's largely a research tool. However, it is used in some centers. And so those data suggest that if you actually are going to use brain tissue oxygen monitoring, then you should maintain a level of PbO2 greater than 10 millimeters of mercury. Again, I would say the clinical uptake of advanced neuromonitoring at the bedside is rather low, but if you're practicing at a level 1 pediatric trauma center, you may have patients that come in with a Lycox probe where you see these data displayed. In addition to an ICP level, you'll also see a brain tissue oxygenation level. And if that happens, then our goal should try to be to maintain PbO2 greater than 10 through either increases in FiO2, transfusion, although the level of evidence to suggest that any of that can actually make a meaningful difference comes from adults, and it's still not clear. So I would say this for the average practitioner in an average context, even at Harborview Medical Center, this is still really considered relatively underutilized and cutting edge. Now, the idea of whether patients should have CT scans or MRIs because of the radiation risk of CTs, particularly when they're repeated, has been a source of conversation. So the recommendation here is that if you don't suspect continued high ICP or deterioration, you really don't need a repeat head CT. And so we're really trying to get systems to move away from routine repeat head CTs. Not only does that, convey radiation risk to children at a time when the brain is actively developing, but there's also a risk for transport, intra-hospital transport related decompensations. And so we're trying to, the purpose here of this recommendation is really to focus on the initial evaluation as a CT and then move to MR if it's needed for prognosis. We did recommend a treatment threshold of of trying to keep ICP less than 20 to improve overall outcomes at the level 3 for recommendations. Now, CPP is a little bit more complicated in children than in adults in terms of recommendation because there are all these age-related changes in hemodynamics that occur. But the best available evidence suggests that we should try to keep a CPP minimum of greater than 40 millimeters of mercury. And there's probably some continuum between 40 and 50 that is required to suggest adequate cerebral perfusion. And there may be age-related thresholds, but the data supporting exactly what those thresholds should be is really not very clear. So I would say CPP greater than 40 at closer to 50 for older children and adolescents is recommended. Now, some of us, who have been around for a long time, really used to using mannitol to treat intracranial hypertension, and then came hypertonic saline, and it's really taken over in terms of what is used clinically to maintain cerebral perfusion pressure and to treat intracranial hypertension. And the reason for that is you don't get the hypotension that you get with mannitol. And so at the level 2, hypertonic saline is recommended for children with severe TBI with intracranial hypertension with a dose of 2 to 5 milliliters per kilo, bolused over 10 to 20 minutes. And there are some recommendations in terms of continuous infusion with a recommendation of 23.4% suggested for refractory ICP. Now, another question that comes up often in the clinical realm is, can you use hypertonic saline through a peripheral IV or an intraosseous line? And you can, if you're using 2 or 3% hypertonic saline. But if you're going to use 23.4%, really should do that through a central line. There are some recommendations for serial monitoring of sodium and also, looking out for complications of thrombocytopenia and anemia. And so, in the context of multiple ICP-related therapies, we really are trying to keep serum sodium less than 170. And also, recognizing that the amount of time children spend in the operating room may not be so long, depending on what happens. But I would say that if we're getting labs, we should probably be obtaining lab values in kids with severe TBI about once an hour, unless the clinical context merits more frequent laboratory evaluation. And this recommendation really is for the ICU and not for the operating room. There's been a lot of discussion as to what's the right sedative, analgesic for TBI, and I would say it's not clear. I think the main point of this recommendation was to make sure that ICU practitioners didn't just bolus midazolam or fentanyl during ICP crises, because there's some data suggesting hypoperfusion. So I think the idea here is bolusing may lead to acute cerebral hypoperfusion. Now, I think it really does not address the reality of our clinical practice, where sometimes we use propofol to decrease ICP in clinical care. I think that, the transient nature of what we do in the operating room to bring things under control is not present in the literature. And so what happens is that those of us who are writing guidelines understand what the realities of the practice are, but then when they're not published and the outcomes of those are not reported, though that practice doesn't translate to guideline inclusion. And then that adds to the disconnect between what is recommended and what practitioners adopt, which leads to lack of adherence to the guidelines. So what I'm trying to share here is that this is a problem with the lack of science from anesthesiology that doesn't make it into the literature to be included into the guidelines, and an opportunity here for us to make such contributions. This is also a recommendation that is largely, I would say, intended for the ICU. At the time that this recommendation for CSF fluid drainage through an external ventricular drain was made, again, I would say this is a little bit of a problem, because most places around the country don't use EVDs for TBI. They're used for subarachnoid hemorrhage in children who need decompression, but not for traumatic brain injury.
Spirit.
And so I think that I'm not sure how relevant this recommendation is. However, if you do have a child who has an EVD, I would say that you can use it to drain CSF for ICP control. Can support and facilitate favorable outcomes through initiating early anti-epileptic administration. There's insufficient evidence to recommend Keppra over phenytoin, for example, based on efficacy to prevent early post-traumatic seizures. And there are some real reasons why we may want to use Keppra, because of the lack of, you don't have the same toxicity as you do with phenytoin. But in terms of efficacy for prevention of post-traumatic seizures, it's not clear which drug is better. Although something should be used, those data are clear. And so you may see patients coming down with, an anti-epileptic hanging. There's also no problem if we choose to hang that anti-epileptic in the operating room as an early, as an opportunity to reduce early post-traumatic seizures. And of course, I won't read all of this, but temperature control, as Dr. Muldowney mentioned in her last presentation, is important. We want to avoid hypothermia due to which causes coagulopathy. We also want to avoid hyperthermia, which increases cerebral metabolic rate and can be associated with cerebral ischemia. Now, I always found this recommendation to be kind of strange, sort of use of an immune modulating diet. This is really comes from data that were presented in the between 2010 and 2017. People aren't doing this anymore. I think the focus is really on the level 3 recommendation, which is really trying to feed kids early after TBI, particularly if they have isolated TBI, they don't have abdominal injuries, you're not worried about gut hypoperfusion, you're not on vasoactive agents. And so there's a big delay in when we feed patients so that when they're discharged from the hospital, they lose a lot of weight, a lot of muscle mass, and they don't recover. So we're shifting our focus away from the level 2 recommendation to really focus on what we think are low-hanging fruit, but very important to do. The adults DECRA studies and other trials published in the New England Journal suggest that decompressive craniectomies are really not, they may be saving lives, but they're not improving neurological outcomes. And so the recommendation for children is really to treat neurological deterioration for ICP control. We really don't think that decompressive craniectomies are going to improve survival, but they may, be useful for ICP control. If you find yourself in a situation where you have a hemodynamic but have refractory intracranial barbiturate therapy is an option, though we used to use thiopental, which was available. It's no longer available. Own anesthesia practice, I would say, there are volatile agents and propofol that can be used instead, but didn't make it into these recommendations because there are no studies to actually show that it works. And so this recommendation is really referring to phenobarbital or pentobarbital coma that is often initiated in the ICU for refractory intracranial hypertension. But those patients may come to the operating room if they're having other procedures being done. So the only level 2 recommendation associated with outcome benefit at the patient level is with respect to 3% hypertonic saline. And unfortunately, the strength of evidence is weak in almost all other cases. But having said that, and by now you may be feeling, why are we talking about this? Because there's no real strong evidence relevant to anesthesiology practice. I would say there are best practices that we can sort of wrap our head around. And so I'd like to just sort of conclude this presentation by talking about something that's very relevant to us, which is, is there evidence that adherence to the guidelines improves outcomes, and what should we as anesthesiologists focus on? So this has been the subject of a large body of work that I've done over the past decade at Harborview in developing a multi-level Pegasus program for the development and implementation of guideline adherence as best as we can, using very liberal criteria such as, age less than 18 trauma and GCS less than 9. And so I'll just skip the slide and talk about the fact that the advantage of having a program at a trauma center that focuses on key performance indicators in the first 72 hours is that we as anesthesiologists can also wrap our head around what are the 2 or 3 things that we need to do, given that there's so many recommendations. Some of them are not really, don't have a solid foundation with level 1, class 1 evidence to make level 1 recommendations so that we can help support favorable patient level outcomes. So I would say that if we were to focus on 3 things that we should, these are the 3 things it should be, which is we should not be hyperventilating children unless they are having active cerebral herniation in the first 73 hours of diagnosis, because that's when the brain is most at risk. We should be maintaining all CPPs as best as we can, greater than 40, and we should not be insisting on NPO status if patients are tracheally intubated coming to the operating room, because that nutritional status is really important for patient level outcomes. And I'll share with you some data where we enrolled 239 children admitted to the emergency department with severe TBI at some point. And we had an opportunity to try to really understand the relationship between adhering to the Brain Trauma Foundation guidelines and outcomes. Even though I've told you there are a lot of holes there, I do want to come away with this from this presentation thinking that guideline adherence is important. And we really tried to look at where, these three key performance indicators: ventilation, nutrition, and CPP. And what we found was that in patients where we really avoided unwanted hypocarbia, maintained all CPP, and started nutrition early and had minimum interruptions of nutrition, those patients did better. And these are really well done analyses looking at relative risks of hospital discharge survival. And so we prospectively tried to push adherence to these key performance indicators based on the Brain Trauma Foundation guidelines, and found that these three really probably, if we can make a difference, it's with these three indicators here. So the paying attention to ventilation, end-tidal CO2s, getting arterial CO2s in these patients and titrating our ventilation strategies, and using vasoactive agents to maintain CPP are all really important. So these are data that are also showing how if you adhere to these three key performance indicators, not only do we impact discharge survival, but we also impact discharge disposition. So higher chance of patients going to inpatient and outpatient rehabilitation as opposed to a skilled nursing facility. And there does seem to be a dose response effect. In other words, if you adhere more, you actually get a greater benefit. So I think we as anesthesiologists can contribute to improving outcomes for children with severe TBI by focusing on these three key performance indicators. Now, some of you may have
really, management of pediatric energy has overlapping domains, and I think this is a great forum to.
So I think that some of you may have heard about the new JCAHO requirements, which are going to ask us to evaluate equity measures in our care. And I think that, as Dr. Eichholz mentioned, there are a lot of social determinants of health issues that are associated with who has TBI and how patients do. And in addition to the overlapping scientific domains, I think we should start to think about what are the social determinants of health and what can be some of the equity measures in our care. So this is a child that I took care of who came to Harborview, who was very sick, a 4-year-old with subdural hematoma requiring emergent craniotomy, who had a lot of severe symptoms and a lot of physiological derangements. As you can see in the CT scan, shows a large subdural hematoma with midline shift. These are all second insults, and we really tried to work hard to save this child. We were not successful, but nonetheless, these are places where we can make a difference. We can really try to correct these physiological disturbances, try to maintain CO2, provide normal temperature, be aggressive in our glucose management, provide the hemostatic resuscitation that the prior presenters spoke about, and try to maintain our perfusion goals. And it does matter. In fact, what we do in the operating room, and these are data that we published in 2017, that when we see hypotension or when we don't correct it or try to correct it soon enough, or our ventilation strategies are lax, these are associated with worse post-op head CT scans, post-operative escalation of care, and in some cases, deterioration of setting. So I think what we do in the operating room matters to the post-operative period and can also impact perioperative outcomes.
We all work together.
So if you're presenting,
goal. So in the operating room, anxiety control is important. If you have, kids coming down, this is they're nonverbal. They
Can
don't
we,
anxiety.
can everybody make sure you're on mute,
Environment,
please?
Hypothermia is the goal. We need to have our blood warmer and sizes of equipment. Priorities of care need to be defined.
Sorry, Dr. Vavilala, I need you to unmute, please.
I'm unmuted.
Perfect. I'm not sure where that noise is coming from.
Okay, I'm not either. I apologize. Can you hear me okay?
So sorry for the distraction. I cannot find anyone unmuted, so
Okay, no, that's fine. Can you hear me okay now?
yes, thank you.
Terrific. So I think, we can use etomidate, propofol, thiopental, which we don't have anymore. Ketamine is also okay. I think we used to not use ketamine because of concerns of high ICP, but the small studies have shown that it's actually, it may be desirable because you have preservation of sympathetic tone. In terms of airway management, direct laryngoscopy or video laryngoscopy with inline stabilization, there are really no studies to direct us one way or another. I think it depends on, what your comfort level is, what equipment you have. In terms of neuromuscular blockade, succinylcholine and rocuronium are both fine. I think you're trying to facilitate a rapid sequence induction and trying to balance that against ICP control. So modifying that is also acceptable. I think that we have to allow for some personalization at the bedside. As I mentioned earlier, transient hyperventilation is okay, but our goal should be to have normal ventilation and normal carbia so that we're not having cerebral ischemia. There is no real reason to use total intravenous anesthetics as a routine initial step for the care of anesthetic care for children with TBI. There are some real downsides to using propofol, for example, because it's a cerebral vasoconstrictor. So at a time when the brain is most at risk, we don't necessarily want to be adding another agent that does that. So a combination of sevoflurane less than 1 MAC and neuromuscular blockade is just fine. Opioids as needed and prudent extubation criteria should be used. So patients who don't have good neurological status when they come down to the operating room, who require postoperative imaging, for example, maybe you don't want to extubate them at the end of the case.
Along our outcome data. If you can't get vascular access, use intraosseous lines.
So in terms of vascular access for resuscitation, as was mentioned earlier, 2 large peripheral IVs and interosseous line should be used. I've placed a number of interosseous lines. They can be placed in any long bone for access, and they work phenomenally well. You just have to secure them so that they don't fall out, them with more permanent vascular access when you are able to do so.
Easy IL data. What about pressors? What should you use?
So in terms of vasoactive agents, there are people who feel like they aren't sure what vasoactive agent is best. And I would say there's a lot of equipoise here. We commonly use phenylephrine as a first line, but in terms of what is more effective in terms of increasing mean arterial pressure, I would say that the data suggests that it's norepinephrine. So if you have a patient who's coming down with a severe TBI, who's hypotensive, I would say that given our recent learnings of myocardial dysfunction, even in children with isolated traumatic brain injury, norepinephrine should be what we should go to in terms of as a first line for vasoactive support.
Again, no good data in kids.
I'm sorry about the slides. I don't understand where the noise is coming from. So I would just like to conclude by saying that, we really should be thinking about TBI in all pediatric trauma. It's a major issue. If you have patients with, particularly with coexisting injuries, if they're coming down with ICP monitors, we should make sure to hook those up and use the data to guide our hemodynamic care. A few years ago, we started trying to figure out how to support anesthesiologists who are caring for children with traumatic brain injury, particularly in areas who don't see a lot of these patients come through. And we developed a real-time clinical decision support tool to see if we could provide pop-ups in our electronic health record systems to do some back-end evaluations of hemodynamics based on age, for example, to guide practitioners regarding laboratory values and blood pressure targets. And what we found was that these were really useful. I think these are feasible to do, whether you have a homegrown system or you're using Epic. And you can work with Epic to try to do this. So in this study, we learned that our clinical decision support system was triggered commonly with high sensitivity providers anesthesia care. So we have Epic. We have now taken our homegrown algorithms and codes and incorporated them into our Epic processes, so that when a child or adolescent with traumatic brain injury comes to the operating room, there's a sort of, under the BPA section, it can be activated by your department. You can activate it manually, and it'll prompt you to when you should get labs, what are some of the targets that you should use. And so when we piloted this, we learned that there was a lot of second insults occurring during TBI care in the operating room. And I would say that, this was an early study, and whether we had CDS or we didn't have CDS, that's clinical decision support, second insults were common. And since then, we've revised our practices so that the prompts are more proactive, more timely, and more relevant. We have to balance some of these prompts in terms of not being annoying for us as we're trying to take care of these very sick kids. But just wanted to share this with you to say that Epic has this feature. If you're interested in this, please email me, and I'm happy to share details on how to access this. So in conclusion, traumatic brain injury is a big deal. I think guidelines are needed to eliminate unwanted care. The guidelines aren't perfect because they don't really address all of the care elements that are as relevant to us as anesthesiologists, but they do provide some framework to avoid the care that we don't want to give. And they don't also ensure personalized or best care. So there may be practices that you have or we have as a specialty that we really need to publish so that they make it into the guidelines for dissemination. And I would say that what we do matters to ensuring that, we can, and there are things we can do regarding ventilation and hemodynamics and systems-based care, and not interrupting nutrition when we don't need to support these children. Thank you. And I apologize for the noise that kept popping up.
Looks like we've got one question off the chat that just happened. Dr. Kloss asks, I was under the impression that propofol was better than inhalation agents in acute brain injury because of the cerebral vasodilation from inhaled agents. Can you expand?
Yeah,
Propofol.
I mean, I think the balance, so we don't have good data, right? I mean, this is part of the challenge. So part of what I'm saying is based on animal data, based on data from small studies. So I don't think that we can say that propofol is better than inhalational agents. The vasodilation that occurs from inhaled agents are really at high doses or doses greater than a MAC. So if you're using a balanced anesthetic technique and you're relaxing patients, then there's no need to use TIVA. And in fact, I don't. I didn't quite understand the second part, which is propofol only in low doses because of. So are you saying that propofol? Are you asking if propofol could be used in low doses, or are you suggesting that it shouldn't be?
When you said that propofol causes intracranial vasoconstriction, I was unaware of that. So that's why I'm thinking if you like should try to avoid propofol, especially maybe for sedation afterwards, or, you
Yeah, I
know,
mean, I think that's a good point. Yeah.
when
So,
the ICP is high, I feel like that would have been something I would have used in a patient who has a high ICP, would be propofol. And now I'm kind of wondering if that should be avoided.
right. So I think there's two different scenarios. One is for ICP crisis, when you have to get the ICP down. And the problem is we don't know whether the high ICP is because of cellular problems, or if it's if it's a vasogenic cause of an ICP, so blood flow is too high. We don't know that because we're not doing advanced monitoring to actually figure that out. So we're kind of going in the dark. I would say that we have shifted as an institution away from propofol, not only because of propofol infusion syndrome, but also because dexamethasone allows for a neurological exam, and you are not concerned so much about the mitochondrial dysfunction that is associated with propofol. So for sedation, we have shifted away from propofol for pediatric TBI to dexamethasone. So if you have that, that is what I would recommend. I think that in ICP crisis, yes, propofol could be used in small doses to bring the ICP down. But I think that for an anesthetic technique, you do want to have some preservation of cerebral blood flow. So my preference is to use low-dose volatile agents with neuromuscular blockades. Let me share with you, since there's plenty of time, Shirley says. So let me just share with you a story of a kid I took care of Harborview maybe about 5 years ago. This was not a patient who was having traumatic brain injury, but was having an aneurysm repair, but the principles still apply. We had a jugular venous catheter in place, and so we were able to sample that to look at oxygen saturations of the brain, right? Jugular venous oximetry. And the patient was receiving a combination of propofol and remifentanil, and the case was a long one. And so we sampled both the arterial gas and the jugular venous gas. And over the course of 6 hours, progressively, and the patient was otherwise stable, progressively observed on TIVA that the jugular venous saturations were decreasing. And so the brain was becoming hypoxic. There was not a lot of bleeding. The hematocrit was fine. The blood pressures were fine. And so I think about hour 3 or 4, I said, well, let me try an experiment and turn the TIVA off. And they were monitoring the brain during neuromonitoring. But I would say that when you have data that shows that the brain cells are becoming hypoxic, I think the risk benefit ratio of that suggests that neuromonitoring should take us, kind of play second fiddle. So I turned the TIVA off and relaxed the patient and put the patient on volatile anesthetic at about a MAC or so. And the jugular venous saturations came up within 30 minutes. So I think if you're asking me the question, if cerebral vasoconstriction with propofol and ischemia is a real thing, I think it is. I think just automatically using TIVA for all TBI cases is not necessary, and in some cases may be detrimental. If you need it because ICPs are high and you can't control it, and I think that's a different scenario. So I think it's a matter of where do you start and where do we escalate if needed? Does that make sense? Did I answer your question?
Yeah, that was actually really helpful.
Yeah.
Any other questions for all 3 of our trauma speakers? I know for one, I take care of patients in Central Oregon where a lot of people come to do dumb things recreationally that tend to involve high amounts of energy. And every time I'm on call, my terrified that I'm going to have a small kid overnight in our hospital. And those two presentations were outstanding. That made me slightly less terrified, still terrified, but less terrified. So you guys nailed it. That was great.
Well, thank you. I think I would say that I still get, very nervous whenever there's a kid who is coming down for trauma. And the reason is, we're a mix, it's not that common that it occurs, right? And it's very high acuity, very high intensity. People are stressed out, and you can't always find the equipment that you want, and you don't have
No, did we lose her?
we've had infants frozen. Okay.
Oh, now you're back.
Okay, so we've recently had some cases of infants with, from child abuse, non-accidental trauma, inflicted traumatic brain injury, all three names for the same thing, who've come down for, subdural hematoma evacuation, and they're hypotensive, and all those bad things happen. We have to be careful not to fluid overload these patients, because we can put these infants into congestive heart failure. So using syringes to give blood or volume or other medications may be preferable. We have these big liter bags that are hanging, and before you know it, it's all in. And sometimes we put these kids into, kids have pulmonary edema from fluid overload. So that's something I didn't say, but I just wanted to mention since we have time.
No, that's great, because I think for a lot of us, trauma means wheel the Belmont in, but in the pediatric world, some of those patients can actually fit inside the Belmont, and
Yeah.
it's a whole different animal. Dr. Heilbrunn, he's one of my partners, asked a question on maximum infusion rates for these guys. Can you expand on that at all?
Dr. Eichholz, you talked about resuscitation in your presentation. So do you want to answer this one, or?
I don't think she's on anymore.
Oh, okay.
I don't see her. Sorry about
Okay,
that.
great. Yeah. So sure. So I would say what I tend to do is put their maintenance fluids on a pump. And then I have a separate line where I'm doing resuscitation for ongoing losses. So that's my strategy for balancing hypovolemia with volume overload. Yeah, so I would say, so hi, Kirk. Yeah, so the ventilator on the machine is sent to default. Well, so yes, I think a lot of our alarms and monitors and settings are set to adult values. So we are also a mixed practice. We have to make sure that the cables are correct and the alarms settings are correct, and also the ventilator should be on pediatric mode, but not adult settings, so that you can either use pressure control ventilation if you want to, or set your lower tidal volumes. Machines have idiosyncrasies in terms of what they actually deliver, and then circuit length, circuit compliance matters in terms of what you deliver. Dead space has to be taken care of, because you're really trying, then it becomes unclear what's the machine, what's the circuit, what's the patient, and it can be quite complicated. So I agree with you. Yes, hi, Stephen. Yes, that's right. I have a question for you folks. So those of you who use Epic, do you have the BPAs that you use for interoperative guidance, or is that something that you would find helpful or annoying? Because nobody wants alarms popping up at them all the time.
We use Epic, but I don't think I can speak to that. We haven't gone into it in that level of detail.
Yeah, no, that would be great. So I'm just going to put my email in the chat box if anybody's interested in sort of you know, the BPAs for Epic. I'm happy to work with our team to share that.
Well, great. Thank you so much, Dr. Valalala and Dr. Eichholz and Dr. Muldowney for helping us out with trauma this morning. Again, those were outstanding presentations. And it looks like we found Dr. Cozella. We're running. And Carrie, am I saying that correctly?
It's Coachella.
Coachella, okay, thank you. We're running a little bit ahead, but I say we should keep moving on with our presentations, and then we'll take a little break after this. Dr. Lawani is going to introduce our next speaker, but I just want to say a big thanks because I believe it's still the case that you're joining us from Hawaii, right?
That's right. Yeah, sorry to join just on time. I'm on Maui time.
You're perfect. I'm hoping for like a large sweeping view of the ocean, but
I can certainly see it if I look to the left.
All right. Well, thank you so much for joining us.
Hello, everyone. It's my distinct pleasure to welcome Dr. Carrie Coachella, who's going to be talking to us about pediatric regional anesthesia. She's currently our Director of Pediatric Regional Anesthesia at Dornbecker. She joined us last year. She has completed a bachelor's degree from the University of Kentucky, as well as her MD from the University of Kentucky with distinction. She then completed a joint pediatrics and anesthesiology residency at Johns Hopkins University, followed by a pediatric anesthesia fellowship at Boston Children's and a pediatric regional anesthesia fellowship also at Boston Children's. Along the way, she took some diversions. She went to St. Andrews for a little bit, where I hear she rubbed shoulders with some royals and some royal progeny. And then she also went to the Solomon Islands to teach critical care, and Malawi in the Philippines. It gives me great pleasure to welcome her today. Go ahead, Carrie.
Good morning, Kirk. Thank you so much for that really kind introduction. And thank you all for inviting me to speak here today about something that is really near and dear to my heart. I'm going to share my screen. Tell me, does it share it in presenter view or does it look normal for you all?
It is not normal.
It is not normal. Okay, so I'll take it out of presenter view then, and we'll just do it the old-fashioned way. I'm capable of doing that. Okay. Sorry, give me just 1 second. Does that look normal for you then?
Right now, we can't see it.
You can't see it at all. Okay. How about that?
That's perfect.
Perfect. All right. Great. So as you heard, I'm presenting to you from a little ways away. I'm in Maui right now. I checked my internet connection last night and it seemed to me like it should be sufficient for this presentation, but please do let me know if there's any lag, if I need to slow down, if there are any problems with the connection. So I was asked to talk to you all today about pediatric regional anesthesia. And when I thought about who the audience would be, that it wouldn't necessarily only be pediatric anesthesiologists or only be regional anesthesiologists, but really for all anesthesiologists, I decided to sort of focus my talk on my thought process of what I think about and what I do when I decide to do a nerve block in a child, so that if any anesthesiologist comes across, say, a middle-sized school-age child who has a really good indication for a nerve block, they might feel more comfortable or more empowered to offer that service to that patient. And I'm really thinking about patients like the very last person I took care of on call before I came here on vacation. I had a 7-year-old who had a lap appy that converted to open. And so he had this big umbilicus to pubis incision. And so we were able to do some abdominal wall blocks for him to help him be more comfortable when he woke up. So that's my goal today. Do me a favor, everybody, and when you read the title of the presentation, use your best Steve Urkel voice in your head. I'm going to spare everybody my own interpretation of that. My objectives today, let me just lower that. My objectives today are to review safety data for pediatric regional anesthesia, including the safety of performing blocks under general anesthesia. I'm going to talk about some key differences in anatomy and in pharmacology between infants and older pediatric patients. It's our infants who are the most different. I'll talk about some unique considerations for performing blocks in children compared to adults. And then I'll talk about my strategy for identifying an appropriate weight-based dose for various types of nerve blocks in children. Oops, I don't have any disclosures today, but you will definitely notice if you look at the pictures that I have a real soft spot for the TV of my childhood. So you'll see some early 90s TJF pictures. This is dinosaurs. This part would be a lot more fun if we were in a room together where we could all raise our hands, but I'd like you to mentally raise your hand and answer the question to yourself of, would I offer a nerve block to this patient if they had an indication for one? So these are pictorial depictions of a woman across her lifespan. And so here we see her in kind of young adulthood to middle age. Would you feel comfortable doing a nerve block for her? So next, ask yourself, what if she's elderly? There's a few more considerations for elderly patients. Would you still feel comfortable then? I think we're in the territory now where most adult anesthesiologists would feel comfortable offering nerve blocks. But what about as she gets younger? What if she's a teenager? Or what if she's a school-age child, like that 7-year-old lap appy I had? Or what if she's, a 4 or 5-year-old? And even worse, what if she's a toddler or an infant? Would you feel comfortable doing a nerve block at those ages? I think for most of our youngest patients, those are the patients that have the largest physiologic differences compared to adult patients. And so those kids are typically the purview of pediatric anesthesiologists who should be doing their nerve blocks. And I'm going to talk a little bit for the pediatric anesthesiologists in the group about some of the differences between infants and older children that apply to regional anesthesia. But for the school-aged and older kids, I think those kids are really fair game for anybody who has the appropriate knowledge of how to apply their adult regional anesthesia knowledge to children. So there's just a few extra things that you need to know to safely do blocks in younger patients. In order to achieve my objectives, I'm going to first talk about the safety of peds regional anesthesia. We should answer the question of, is it safe to do nerve blocks in children? And then I'm going to tell you why the pediatricians told me in residency that children are not little adults, why they have some unique physiologic needs and unique psychological needs that we need to be mindful of when we're doing nerve blocks. And then I'm going to talk you through my roadmap or my thought process for how I do a safe block in a pediatric patient. And that should be most of the talk, about half of it. So here's a couple pictures depicting one of our smaller pediatric patients and maybe one of the younger adult patients that one might encounter in anesthesia practice. And there's a lot of differences between doing a nerve block in these two populations. So on the left-hand side, we have, a 3 or so kilo neonate who is under general anesthesia, who perhaps has got neuromuscular blockade and is certainly very small. And then on the right, we have an adult patient who's getting an awake or a lightly sedated block and has a lot more kilos available when choosing local anesthetic volumes. And so I think it's a very good question to ask, given how different it is to do nerve blocks on smaller patients, is it safe to do nerve blocks on pediatric patients that are small, who are getting blocks done under general anesthesia, et cetera? Fortunately for us, because this is such a worthwhile question, a lot of organizations have done large-scale prospective safety studies to try to answer it. So the first large-scale study came out in 1996. It was done by the French Language Society of Pediatric Anesthesiologists, and they prospectively collected data on 24,400 nerve blocks, a combination of both peripheral and neuraxial procedures. In 2007, not to be outdone, the Association of Anaesthetists of Great Britain and Ireland asked the question of, was it safe to do epidurals under general anesthesia? And so they collected data on 10,000 pediatric epidurals. By 2010, the practice of pediatric regional anesthesia had changed pretty greatly. And so the ADARPEF, the French Language Society, decided to repeat their study. So now we were doing a lot more peripheral nerve blocks compared to neuraxial procedures, and we were using ultrasound a lot more rather than doing landmark-based nerve block techniques. And so they collected data on an additional 31,000 patients. By 2012, the North American institutions got in on the game, and the Pediatric Regional Anesthesia Network, which is a collection of institutions who take care of pediatric patients in North America, in the United States and Canada, they started publishing the first of their data. So in 2012, PRAN published data on about 15,000 blocks, and they've been continuously publishing their data since as they collect more and more patients in the network. So by 2014, they were up to 53,000 blocks. And most recently, in 2018, they published data on 104,000 pediatric nerve blocks. So in sum, if you add the patients for all of these large-scale prospective safety studies together, we have data about the safety of pediatric regional anesthesia for 170,000 patients who got a combination of peripheral nerve blocks and neuraxial blocks. So arguably, the safety data is more robust in pediatric regional anesthesia than it is in adult regional anesthesia. For the sake of time in detail, I'm only going to review the largest and the most recent of those studies. This is that 2018 most recent PRAN study called Complications in Pediatric Regional Anesthesia. So this is a prospective audit where data was collected between 2007 and 2015. And by the end of the collection period, more than 20 centers participated, including our own hospital, OHSU. They collected data on a total of 104,000 and about 400 nerve blocks. And certainly they did see some serious complications among these 104,000 blocks, but they were very few. So there were 11 cases of mild LAST as defined by EKG changes or a metallic taste in the mouth. And there were 7 cases of severe LAST, 4 of which were cardiac arrest and 3 of which were seizures. The risk of having LAST, they estimated to be 0.76 per 10,000 blocks. They had a single epidural abscess in the study, also a risk of 0.76 per 10,000 blocks. They had a single epidural hematoma, which interestingly didn't come from an epidural, but from bilateral paravertebral catheters, which we know can migrate into the epidural space. They had 1 pneumothorax that not surprisingly came from a supraclavicular block. They had a significant misadventure with a caudal catheter that ended up in the intra-abdominal space. There were no permanent motor deficits identified in this study, so they estimated the risk of permanent motor deficits for a pediatric nerve block to be 0 to 0.4 per 10,000, and that's compared to the adult risk of about 2 to 4 per 10,000, so much lower risk in pediatric patients. And they only identified 2 sensory deficits that lasted longer than 6 months. There were some more minor complications that were a little bit more frequent, of course. So the risk of transient neurologic deficit was about 2.4 per 10,000. This was slightly more common for peripheral nerve blocks than it was for neuraxial procedures. The risk of cutaneous infection was about 0.5%. And unsurprisingly, they found that that risk increased day over day by about 6.7%, confirming what we all know, which is that catheters should be removed as soon as they're not needed, but they definitely have an expiration date. And the most common risk that they saw by far was catheter failure at a rate of 4%. So all in all, in this study, they found that the risk of severe complication was quite low, typically as low as or lower than rates reported in adult safety studies. So hopefully I've convinced you that it is safe to do nerve blocks on pediatric patients. And now we're going to switch gears a little bit and talk about why children, especially our smallest children, are different than adults, and talk about their unique needs that we have to respect when we're doing regional anesthesia. So I'm going to contradict myself here in a second and tell you about the one complication that is probably much more common in our smallest pediatric patients than adult patients. So there's one thing that we really need to be mindful of. These are two tables that were taken from that 2018 PRAN paper, where they looked at the risk of neurologic complications and the risk of LAST by age. So in the table on the left, we've got neurologic complications divided out into different age groups. And you can see that neurologic complications are most common in kids who are 10 years of age and above. And we really start to identify them in kids who are 3 years of age and above. I'm positive that part of the reason that we're not identifying any neurologic complications in our kids younger than 3 is one, motor complications are very rare in kids, but also kids under 3 aren't able to report temporary neuropraxias to us. So I'm sure that we're probably missing some sensory injuries. But in general, this risk the risk of severe motor injury seems to be low in our youngest pediatric patients. The one risk that is definitely highest in the youngest patients is the risk of LAST. So this second table on your right divides the incidence of LAST out by age, and you can see that the incidence is the highest in infants who are 1 to 5 months of age. So they have a risk of 5 per 10,000 compared to the risk in children who are over 10 of only 0.3 per 10,000. When they did an analysis to investigate this and adjust for all of the various confounding factors, they found that the odds of infant under 6 months of having LAST was about 7.5 times higher than older patients. And so this begs the question of why. Why is it that our infants are the most predisposed to getting LAST? And it turns out that they have several risk factors that predispose them to local anesthetic systemic toxicity. So the first risk factor that they have is that they have decreased plasma levels of alpha-1 acid glycoprotein. And alpha-1 acid glycoprotein is an acidic plasma protein. It likes to bind to basic local anesthetics and decrease the free fraction that's available for binding. So if you have less alpha-1 acid glycoprotein floating around in your bloodstream, you have a higher free fraction of local anesthetic that's available to bind to your sodium channels in your CNS and in your heart. They also have an immature cytochrome P450 system. And I'm sure you remember that most of the local anesthetics that we use for nerve blocks, like ropivacaine and bupivacaine and lidocaine, are metabolized by the P450 system. And so because of that immaturity, they have decreased hepatic clearance. And this predisposes infants to accumulating their plasma levels, to getting higher and higher plasma levels with repeated boluses of local anesthetic or with infusions of local anesthetic. And so for this reason, most pediatric anesthesiologists will use either lidocaine, which you can monitor levels for and which has a higher hepatic extraction ratio, so it's metabolized slightly better, or chlorprocaine, which is metabolized by pseudocholinesterase for infusions in infants under the age of 3 to 6 months. And if they use ropivacaine, they will significantly lower the doses. Infants have a couple of cardiovascular risk factors for cardiac LAST. They have a higher cardiac output, and this means that when you put a bolus of local anesthetic in, they're going to absorb that bolus from the tissue much faster, leading to a higher initial plasma concentration. And by the way, this also tends to make your block not last as long. And they also have a higher heart rate, and that increases their vulnerability to cardiotoxicity of local anesthetics, which like to bind to cardiac sodium channels when they're in the open state, and they're open more often if your heart rate is faster. Finally, infants have an immature blood-brain barrier, and this increases the uptake of local anesthetic from the bloodstream into the CNS, which predisposes them to neurotoxicity. They do have a single protective factor. Infants have higher total body water, so they have a very high volume of distribution, which means that your initial peak plasma concentration after a single bolus will be lower in infants than it will be in older children. But this is not helpful for repeated boluses, and it's not helpful for continuous infusions. So overall, infants have a lot of physiologic reasons why they're predisposed to LAST. So now we're going to talk about another thing that makes infants unique, and that is how their physiology relates to spinals. So all pediatric providers know that spinals have a significantly decreased duration of action in infants compared to older children. And there's a couple of reasons why this is thought to be. First, infants have a very high cardiac output, as we mentioned before, and that increases the absorption of drug from the intrathecal space into the vascular space and away from the CNS. Also, they have a higher turnover rate of CSF, increasing the rate of elimination of local from the intrathecal space. And finally, traditionally, we're taught that infants have a higher CSF volume per kilo. So in preterm infants are thought to have about 11 cc's per kilo, term infants 15 cc's per kilo of CSF, as opposed to older adults and children who have only 2 cc's per kilo. So perhaps that explains why spinals don't last as long. I will say, when I was doing research for this talk a while ago, I found an interesting MRI study from 2016 where they did MRIs on neonates and found that they only had about 2 cc's per kilo of visible CSF volume on imaging. So perhaps calling that traditional teaching into question. But whatever the case, infants certainly have decreased duration of action of spinals. Also, infant spinals have to be dosed much higher than spinals in adult patients. So typically, infant spinals are dosed with either bupivacaine or tetracaine. I'm going to talk about bupivacaine because we use it a lot for adult spinals as well. So infants who are less than 5 kilos need about 1 milligram per kilo of bupivacaine compared to 0.5 mg per kg in infants who are 5 to 15 kilos and 0.3 mg per kg in infants who are 15 kilos. And if you think about the last cesarean section that you did, where an adult woman got maybe 12 to 14 milligrams of bupivacaine, compared to a 5 kilo infant who's getting 5 milligrams of bupivacaine, you can see that there's a much higher dose per kilo needed in our infants compared to our adult patients. The one really fun and satisfying thing about doing spinals in infants is that they have an immature sympathetic nervous system. So they live in a parasympathetic predominant state, which means that if your spinal blocks the entire intermediolateral cell column, blocks all of their sympathetic output, it doesn't have as much, or sometimes often any hemodynamic consequence for infants because that sympathetic nervous system is still immature. So our youngest patients typically have very little hypotension or bradycardia from spinals because they're living in a parasympathetic predominant state. There are some anatomic differences about infants that we have to be aware of anytime we do any sort of neuraxial procedure for them. So the first thing is that intercrystal line, that line that you draw in your head between the 2 iliac crests in order to identify the L4 vertebral body. That line is lower in infants. It's down at about L5S1. And so if you're not aware of that, there's a risk of doing your neuraxial procedure lower than you intend to, or not realizing that you have room to go up another space and try again. Secondly, the neonatal dural sac ends down at S3, S4 compared to S2 in adults. And so that means if you're doing a caudal in a young infant, if you stick your needle in too deep, the fecal sac is pretty close to S5 where you're doing your caudal, and you can risk puncturing the intrathecal space. Thirdly, the spinal cord in infants ends down at L3 compared to L1, L2 in adults. And that means that if you're doing a spinal in an infant, if you do it too high, you're at risk of hitting the spinal cord with your needle. And so it's important to always remember that in infants, spinals need to be performed below the level of the L4 vertebral body in order to be sure to miss the spinal cord. So lastly, we're going to talk about how not just infants, but younger children are different than adults in terms of their metabolism of heparin. So young children and infants who are smaller than 45 kilos require twice daily dosing for Lovenox prophylaxis. Because they metabolize it more quickly than the once daily dosing Lovenox prophylaxis that's acceptable in adults isn't pharmacokinetically feasible to them. For them. And the reason that I mention this is that you might remember from reading your Azra Coags app that indwelling catheters in adult patients are permissible with once daily Lovenox dosing, but are not permissible with twice daily Lovenox dosing because of an increased risk of bleeding. But this is not true in young children who are less than 45 kilos, who pharmacokinetically need twice daily Lovenox dosing. So for those patients, they can have an indwelling catheter with twice daily Lovenox dosing without an increased risk of bleeding. If you're interested in reading more about anticoagulation practice guidelines for pediatric patients, there are a couple of great sources. So there's a 2010 guideline that was published by the French Language Society of Pediatric Anesthesiologists that unfortunately is published in French. There is or unfortunately for me at least, there is a 2018 guideline from Great Britain and Ireland that we can all read. And then in 2022, if you were to look at one source, look at the ESRA Practice Advisory on the Prevention and Management of Complications in Pediatric Regional Anesthesia. So this very recent practice guideline has an entire section about anticoagulation and regional anesthesia in pediatric patients. And it has a really lovely summary table that summarizes the previous 2010 and 2018 guidelines. I didn't reproduce it for you here in part because it's going to look very similar to the ESRA guidelines that you're already familiar with. I pointed out to you the biggest difference, which is that it is permissible to leave catheters in children who need twice daily Lovenox prophylaxis because of their pharmacokinetics. So that completes our children are not little adults section, and we're going to move on now to my roadmap or my thought process for how I safely do nerve blocks in pediatric patients. First, we're going to talk about how everything you know about doing nerve blocks in adult patients still applies. You still need to get a really good history and physical exam and make sure that there aren't any contraindications to regional. Next, you have to choose if you want to do your nerve block awake versus sedated versus asleep, and we'll talk about the safety data for that. Then you have to pick your local anesthetic and what adjuvant agents you want to add to it. You have to pick your volume. And then I have a couple strategies I'd like to share with you that I use to minimize the risk of causing nerve injury or LAST in our smaller patients. And lastly, we'll talk about the importance of communicating with your anesthesia and surgical teams to make sure that everyone together isn't accidentally giving your patient an overdose of local anesthetic. So first, let's talk about everything we all already know about doing nerve blocks in adult patients. All of those safety considerations still apply. You don't have to throw the baby out with the bathwater. So you need to first get a good neurologic history and exam to assess the patient for any pre-existing neurologic injury. So patients who have pre-existing neurologic disease are more predisposed to getting nerve injury from nerve blocks because of this double hit phenomenon where their pre-existing disease is the first hit to the nerve and the nerve block can perhaps be the second hit and therefore predispose them to having more permanent neurologic injuries from nerve blocks compared to temporary neuropraxic injuries. So if your patient has pre-existing neurologic disease, that might change your calculus about the benefit of offering a nerve block to that patient. Fortunately for us in pediatric anesthesia, pre-existing neurologic disease in the forms of things like diabetic peripheral neuropathy are very rare, which I think helps add to the safety profile of peds regional anesthesia. Next, you have to get a bleeding history from your patient and make sure that they're not on any anticoagulant medications that would put them at risk of a hematoma. Also, you need to ask about significant hepatic, renal, or cardiac impairment that might predispose them to getting LAST and necessitate you to lower your acceptable doses of local anesthetic. If you're doing brachial plexus blocks, of course, you need to screen for severe pulmonary disease. You need to screen for signs of infection, both systemically and then locally at the site of needle insertion, and ask about any relevant allergies that might be a contraindication to doing your nerve block. So all of the things that we all already know, they still apply. The second thing that I think about is how am I going to do my nerve block? Am I going to do it awake, lightly sedated, deeply sedated, or completely asleep? And I think if you look at these beautiful crying faces, it's pretty obvious that these youngest patients are not going to cooperate with a lightly sedated nerve block and that general anesthesia is the safest way to do nerve blocks for them. I think that it is a little bit less obvious to people that this teenage patient might also be better served by having her nerve block done under general anesthesia compared to light sedation. And that's because our teenagers don't have completely developed brains. They aren't necessarily able to cooperate when they're very anxious the way that older adults might be able to. And if they're not going to cooperate well with you, it might be safest for them just to have them to be asleep. If we go back to those large scale safety studies, we look at the most recent one from each group, we can see how commonly people are doing nerve blocks under GA versus lightly sedated or awake. So in the British study from 2007, 99.99, so all but one epidural in that study was done under general anesthesia. In the most recent French study from 2010, 96% of nerve blocks were being done under GA. Of those nerve blocks, about 1/3 were neuraxial and 2/3 were peripheral nerve blocks. And in the 2018 PRAN data, 94% of nerve blocks were done under GA, of which about half were neuraxial and half were peripheral nerve blocks. So if you look at what pediatric anesthesiologists are actually doing, they are doing the majority of their nerve blocks asleep under general anesthesia or deep sedation. This is a table that comes from that 2018 PRAN paper where they divide patients into various age groups and they look at the frequency of doing blocks awake, versus under general anesthesia. So you can see that there are two different sort of extremes of age in our pediatric populations that are tending to get a little more of their blocks done awake versus asleep. So the first group is our infants who are under 6 months of age. So they are, the awake block that they are tending to get is spinals in order to avoid general anesthesia. And the other group that gets more awake blocks is our children who are older, who are 10 years of age and older. They're getting about 14.6% of their nerve blocks awake or lightly sedated versus under GA. What this means, though, is that they're still getting the vast majority of their blocks asleep. So 85% of blocks done in kids 10 years of age and older are still being done under general anesthesia. They did an analysis in this paper to try to determine the safety of doing nerve blocks awake versus asleep. And they found that the risk of having a neurologic complication or LAST when a patient was under general anesthesia is about 2.2 per 10,000 blocks. And if a patient is awake or lightly sedated, it's about 15 per 10,000 blocks. And you're going to remember, I'm sure, that I just told you that neonates are getting, and young infants are getting more blocks awake, and that neonates and young infants are more predisposed to LAST. So they very smartly did age adjust this analysis. And they still found that the risk of having a severe complication and was about 3 times higher in patients who were awake compared to patients who were under general anesthesia. So perhaps it is safer to have a patient who is asleep but cooperative compared to a wiggling awake patient. This safety data has been reflected in our practice advisories over the years. So the first practice advisory that talked about the safety of doing nerve blocks under general anesthesia came in, was the ASRA practice advisory on neurologic complications in regional anesthesia that came out in 2008. And so at that time, ASRA said that it may be better to have an asleep and cooperative child compared to an awake and communicative child. By the time the 2015 second practice advisory came out, they had made an even stronger recommendation that now it likely is better to have a asleep and cooperative child compared to an awake and communicative child. And then later that year in 2015, Ezra and ASRA, they published a joint practice advisory on controversial topics in pediatric regional anesthesia. And at that time, they made an even stronger statement that performing nerve blocks in children under GA or deep sedation is the standard of care. So if you're doing a nerve block in a child under GA, you don't have to worry. This is the standard of care, and this is the way that most providers are doing nerve blocks in pediatric patients. So once you've decided awake or lightly sedated versus asleep, and I will tell you that personally, I do the majority of my nerve blocks asleep, unless I've got a really cooperative teenager, or I think thoracic epidurals are probably the most, in teenagers, are probably the most common block that I do lightly sedated. But the majority of my blocks I'm doing asleep. The next thing that I am doing is choosing my local anesthetic and what adjuvants I want to add to it. So I need to pick my type of local anesthetic, I need to pick the concentration of it, and then I need to pick what I want to put in it to help it to last longer if I need that. There are a couple of practice advisories that have come out that recommend that either ropivacaine or levobupivacaine should be used for pediatric nerve blocks because they have lower cardiotoxicity profiles and our younger pediatric patients are more predisposed to LAST. Because levobupivacaine is not marketed in the US anymore, that means that ropivacaine is the local anesthetic of choice for pediatric regional. So Young children who are under 2 have higher baseline heart rates. And as we talked about before, that increases their risk of cardiotoxicity. And also, our youngest children are getting the highest doses of local anesthetic in terms of milligrams per kilo. So our smallest children, who are the most predisposed to cardiotoxicity, are also getting the highest doses for any given nerve block in order to achieve an effective block. And you don't have to take my word for that. This is a box plot that I pulled from a Korean paper that looked at practice variability and dosing for pediatric nerve blocks. And this plot shows you on the x-axis various age groups of pediatric patients, and then the y-axis is the average dose of local anesthetic given for a nerve block in bupivacaine equivalents per kilo. So the youngest patients are infants here who are under 12 months of age. They're getting on average more than 1 mg per kg of bupivacaine equivalent, compared to our oldest patients on the right who are getting more like 0.7 mg per kg of bupivacaine equivalent. So our youngest patients are getting the highest doses of local anesthetic in order to achieve an effective block. Once you've picked your local anesthetic, the next thing you have to do is decide what concentration you want to use. Do you need anesthetic concentration or do you need an analgesic concentration? And because the vast majority of my patients are going to get general anesthesia for their surgery anyway, I'm almost always choosing analgesic rather than anesthetic dosing. I think the last time I did an anesthetic nerve block was for somebody who had severe pulmonary hypertension, where my nerve block was going to be my primary anesthetic. So the reason I like to choose analgesic rather than anesthetic dosing is several-fold. First, if I pick 0.2% ropivacaine rather than 0.5%, there's fewer milligrams of ropivacaine in my block, and so that lowers my risk of LAST. Also, all local anesthetics are neurotoxic, and the more concentrated they are, the more neurotoxic they are. So it lowers my risk of neurotoxicity to use less concentrated local. If I'm doing multiple nerve blocks, especially, it gives me greater volume available to try to do multiple nerve blocks at the same time. And finally, for our youngest patients, you actually get a denser block from a lower concentration of local anesthetic compared to older patients. So our smallest patients have really small diameter nerves, and the myelin sheath is not complete yet, and their indonurium has less connective tissue. And when you add all these things together, what that means is that the local is able to penetrate better. And so you have a higher risk of motor block and a higher risk of a prolonged motor block in your youngest patients when you give the same concentration of local that you might give to an older patient. So in sum, 90+% of the time when I'm choosing local for a nerve block in kids, 0.2% ropivacaine is what I'm using. Next, I have to decide if I want to put an adjuvant in it. And there are some recommendations that come from a 2018 ASRA dosage recommendation paper for pediatric regional anesthesia. The only adjuvants that they support in that paper for pediatric nerve blocks are the alpha-2 agonists dexmedetomidine and clonidine. They specifically talk about dexamethasone and recommend against it for pediatric nerve blocks. One, because there's insufficient data in pediatric patients, but also there's data that shows that if you give those medications IV, that they have the same effect as if you were giving them perineural. And so you reduce your risk of drug error and you reduce your risk of neurotoxicity by giving them peripherally rather than perinaturally. They don't make any mention about the more exciting or more novel adjuvants, medications like buprenorphine, but these medications certainly haven't been studied in children, and so I wouldn't recommend them. And they don't talk a lot about epinephrine, but personally, I avoid epinephrine in any peripheral nerve block that I do under general anesthesia because epinephrine significantly increases the neurotoxicity of local anesthetic. So if my patient is awake, they cannot tell me if they feel a paresthesia, if my needle gets too close to the nerve. So if I were to accidentally do an intraneural injection, if it was just ropivacaine alone, chances are that is might cause a neuropraxia that will eventually go away and that the patient would recover from that. If I inject into the nerve ropivacaine with epinephrine, that is much more toxic to the nerve and significantly increases the risk that I will cause a permanent nerve injury for that patient that will never go away. So I use epinephrine sometimes in neuraxial procedures, but I don't ever use it for my peripheral nerve blocks. Instead, I'm adding typically clonidine or Precedex to those. In terms of dosing for dexmedetomidine or clonidine, if you're giving it perinaturally, you're giving 0.5 to 1 mics per kilo, and you can dose them both basically the same. And if you're doing an epidural, most people use clonidine because it has a really long safety record in pediatric neuraxial procedures, and we're giving about 1 to 2 mics per kilo. The next thing that you need to do is decide how much local anesthetic you want to use for your nerve blocks. You've got to pick your volume. And it's very obvious that this really small infant would need a smaller volume for any particular nerve block than an adult-sized patient would. And because our pediatric patients vary in size, there's a really large practice variability in terms of how much local any given anesthesiologist is giving for a block in a certain size patient. Fortunately, if you're interested in seeing what others are doing compared to what you're doing for a particular nerve block, there are 2 really wonderful PRAN papers that have evaluated this practice and variability. The first one is called Local Anesthetic Dosage of Peripheral Nerve Blocks in Children, and then the second one is Variation in Local Anesthetic Dosing for Peripheral Nerve Blocks, for pediatric peripheral nerve blocks. And I'm going to show you a table from each one of those papers. So this table comes from the first paper. And what they've done is they've shown you various nerve blocks and then the mean dose in terms of milligrams per kilo of either bupivacaine or ropivacaine and the mean volume in cc's per kilo that people are using. And so if you are doing, say, an adductor canal block and you're curious, what are other pediatric anesthesiologists doing, or what are other anesthesiologists doing for that block, you can look at this paper and see how many milligrams they're giving and how much volume they're giving as well. This second graph comes from the second of those 2 papers that was looking specifically at practice variability. These are density red plots. And on the y-axis, you see sort of the frequency with which someone chooses a particular dose. And on the x-axis is the dose that's being chosen in terms of bupivacaine equivalents per kilo. And so each one of these pictures represents a different nerve block that's being done. And you can see that, especially for some nerve blocks like penile nerve blocks, there's a really large practice variability in terms of what different anesthesiologists are choosing for particular blocks. But you can also see that most of these graphs have a peak that will show you the mode or the most often dose that's being chosen for those blocks. So this is a second resource that you can use to sort of double check yourself and see what are other people doing for a given nerve block. Personally, I think that it is not very helpful to list 12 different types of nerve blocks and give you 12 different dosing recommendations for all of those. I think what is more effective and what you're much more likely to remember is the logic behind how much volume you need for a particular nerve block. So this is the way that I teach the residents and fellows that I come across. If you're doing a nerve block where you're trying to fill up a plane or fill up a compartment, I think it makes sense that you need a lot more volume than if your needle is pointing right at a nerve and you just need to put enough local to surround that nerve. So for plane or compartment blocks, things like transversus abdominis plane blocks, quadratus lumborum blocks, fascia iliaca blocks, where you've got to fill up a really big space, you need about 1/2 of a cc per kilo of volume in order to get that spread. If you're sticking your needle right at a nerve, you don't need as much volume to surround just that nerve. So more like 1/4 of a cc per kilo is a right amount of volume for a brachial plexus block or for a lower extremity block. And then there's a third category that I mentioned, and that's there's a few blocks that are where the nerve is in a really small confined space. And so you don't need quite so much volume. These are things like rectus sheath blocks or suprazygomatic maxillary nerve blocks. And for those blocks, something more like 0.15 cc's per kilo is effective. But in general, if you remember anything from this slide, I would remember those first 2 doses. That plane and compartment blocks where you've got to fill up a big space, you need about 1/2 of a cc per kilo. And if you're pointing your needle right at a nerve, you only need about 1/4 of a cc per kilo. If you're trying to do neuraxial dosing, so for an epidural, for thoracic epidurals, you need about 0.3 cc's per kilo. And then for lumbar epidurals, you need slightly more volume, more like 1/2 of a cc per kilo. And then if you're dosing a caudal, you need anywhere from 0.5 to 1.25 cc's per kilo, depending on the dermatomes that you need to cover with your caudal. So if you're doing sort of perineal surgery and you only need to cover your sacral dermatomes, about 1/2 of a cc per kilo is acceptable. If you need to cover lumbar dermatomes, you need more like 1 cc per kilo. And if you're doing abdominal surgery where you need to cover thoracic dermatomes, you need a higher volume, about 1.25 cc's per kilo. So a lot of providers still dose coddles with 0.25% bupivacaine, and notice that you cannot give 1.25 cc's per kilo of 0.25% bupivacaine. That is a toxic dose of bupivacaine. So if you need to cover thoracic dermatomes with a coddle, I've got a couple recommendations for you. One, you can use ropivacaine. There's fewer milligrams per cc in 0.2% ropivacaine compared to 0.25% BP. So that gives you more available volume. Or the second recommendation I have is to draw up the maximum amount of bupivacaine that you feel is safe to give your patient, and then just dilute it with saline to the volume that you need to reach. Once you decide the volume that you need, the next thing that you should always do, I cannot state always enough, is make sure that the number of milligrams of local anesthetic in that volume does not exceed the safe threshold for your patient's age. So because I use majority ropivacaine, and I'll tell you the number of cc's per kilo that you can have for a couple different concentrations of ropi. So I use 2.5 mg per kg as my maximum dose of ropivacaine. I do that in part because it's the same dose that I use for bupivacaine, so it makes it easier to teach the trainees that I work with. And 2.5 mg per kg of 0.2% ropivacaine is equivalent to 1.25 cc's per kilo. And of 0.5% ropivacaine, it's equivalent to 0.5 cc's per kilo. So typically, rather than doing the milligram calculation, in my head, I think about cc's per kilo. I kind of skip that milligram step. Now that I've chosen how I'm going to do my block, what kind of local I'm going to use, what I'm going to put in it, how much volume I need, the next thing I do is I think about what strategies I can use to minimize the risk of causing LAST or a nerve injury to this patient. So I've got a couple strategies to talk about with you. The first one is when I'm doing blocks in pediatric patients, especially the smaller patients where their nerves and vessels, they're tiny, they're really close together, they're really superficial. It makes it a lot easier to accidentally stick your needle into something you don't intend to if you're doing an out-of-plane technique and you can't see the needle tip the whole time. So most pediatric regionalists choose an in-plane technique whenever possible to always see the tip of the needle and make sure that they don't end up inside something they didn't intend. Also, if I'm doing a nerve block that has a particularly high risk of causing a nerve injury, and I'm thinking about interscalene blocks in particular here, sometimes I'll use nerve stimulation in order to make sure that my needle isn't too close. So I'm not using nerve stimulation to identify the nerve roots. I can see them very well on ultrasound. What I'm doing is I'm making sure that there isn't a twitch present at less than 0.5 milliamps, that I'm not too close to the nerve and perhaps inside the nerve when I give my injection, because my patient isn't able to tell me if they feel paresthesias or not. If I'm going to do this and I'm not the primary anesthesiologist in the room taking care of the patient, it's really important to communicate the desire to use nerve stim with the anesthesia team so they don't intubate the patient with a non-depolarizing paralytic, and then you can't use your nerve stim anymore. When you're injecting local anesthetic in pediatric patients, because especially our younger patients are at higher risk for LAST, it's important to inject really slowly and to aspirate very frequently. So in an adult patient, frequent aspiration usually means that you aspirate every 5 cc's or so. But for many of my pediatric patients, their entire nerve block isn't 5 cc's, which begs the question of what is a small aliquot to aspirate in a pediatric patient? And there are recommendations for this, actually. It's recommended that you aspirate every 0.1 to 0.2 cc's per kilo. That's what's considered a small aliquot in a pediatric patient. So for your 10 kilo patient, you're going to aspirate every 1 to 2 cc's. Of course, aspirate intermittently between every aliquot, and someone should keep their eyes glued on that EKG tracing to make sure between all of these small aliquots that we're not seeing changes in the T wave that could indicate LAST. Specifically for epidurals, we're going to talk in 1 second about why I prefer to use saline for loss of resistance compared to air. And then we'll talk a little bit more about a test dose, which you can consider using, but is not as helpful in pediatric patients as it is in adult patients. So talking specifically about doing epidurals in small children, anytime I do loss of resistance, I prefer to use saline instead of air. And this is because if my needle accidentally ends up in the intrathecal or the intravascular space, if I inject air into those spaces, I can cause injury to my patient. So if I inject air into the intrathecal space, I can cause attention pneumocephalus in a really small baby. And if I inject air into the epidural veins, I could cause a venous air embolism, and a fatal volume of venous air embolism is only 3 to 5 cc's per kilo. Or I could cause a paradoxical air embolus. So for those of you who aren't pediatric providers and haven't had to think about paradoxical air emboli for a while, a paradoxical air embolus occurs when air gets injected into the venous system, and instead of being filtered out by the lungs like normal, it shunts from the right to the left side of the heart, and it ends up in the arterial circulation, where it can go into the coronaries and cause coronary ischemia, or it can go into the cerebral arteries and cause ischemia to the brain. And pediatric anesthesiologists are all very paranoid about air in IV lines, because we know that children who are under 5 years of age tend not yet to have anatomic closure of their PFO. So they all have a potential right to left shunt in their hearts that could open if pulmonary pressures were to rise because the patient, say, got hypoxemic or hypercarbic. So the official recommendations from ESRA are that you should limit air to 0.5 to 1 mLs if you're using a loss of resistance technique to air. This is particularly important if it takes multiple attempts to get an epidural. That's when you can really accidentally put too much air into the space. But I say that you should avoid air if at all possible and just use saline for your loss of resistant technique. Finally, we'll talk a little bit about test doses. So the value of the test dose is somewhat diminished in pediatric patients compared to adults because they just aren't as reliable. So kids have a higher resting heart rate. Also, we're often doing their blocks under general or deep sedation, or they've been given a heavy pre-medication before their block, which blunts the effect of the epinephrine. So if we look at the safety studies that we were talking about and we identify those children who had LAST, we can see that the majority of them actually had a test dose that was negative and they still developed LAST. So in the 2010 French study, 6 of the 15 patients who got cardiac LAST had a negative test dose and still developed LAST. And in the 2018 PRAN study, every single patient who had an epidural or a caudal and got LAST, all of them had a negative test dose and still developed LAST. And so they did an analysis where they looked at if using a test dose diminished the risk of LAST, and they found that it didn't. Which suggests that test doses are optional in pediatric patients. Personally, I test dose any epidural catheter that I place because I'd like to know if that catheter is intravascular, but I know that if my test dose is negative, that doesn't mean that that catheter couldn't still be in an ill-advised place or that my patient couldn't get LAST. When you do a test dose, what you're looking for is EKG changes. So that's the earliest and the most sensitive finding. You're going to see it within 20 to 40 seconds of your initial bolus of local anesthesia. In young children, you're looking for peaked T waves or an increase in your T wave amplitude. And in older children and adults, you tend to see T wave inversion instead. You should know, however, that if your patient is under a propofol remifentanil TIVA, that T wave changes are unreliable. And instead, you should be looking at the diastolic blood pressure to elevate. That's the more reliable finding under a prop-remi TIVA. You can also look for the classic heart rate change of an increase in heart rate of 10 beats per minute or more, or for the more ominous findings of bradycardia or cardiac dysrhythmia. But know that about 25% of patients who have positive test doses don't have any change in heart rate. So that's not a 100% reliable finding. And of course, you can look for the classic increase in systolic blood pressure as well, but keep in mind that in children, we often don't have arterial lines when we're doing nerve blocks. And so we're intermittently measuring blood pressures, and it's pretty easy to miss those transient increases in blood pressure if you don't cycle your cuff at just the right time. So remember, test doses are discretionary in pediatric patients. Again, I use them when I place catheters in neuraxis, but tend not to use them otherwise. And know that if your test dose is negative, there's a really high risk of false negative test doses. So that doesn't mean that your patient isn't going to get LAST, but if it's positive, there's actually quite a low risk of false positives in pediatric patients. So any change in T waves or increase in heart rate of 10 beats per minute or more within 30 to 90 seconds of that injection, that should be considered a true positive, and you should reposition your needle or reposition or remove your catheter. So any positive should be considered a true positive and respected. And finally, it's really important when you're doing nerve blocks in kids who, as you remember, are getting larger doses of local per kilo to have an effective single shot nerve block. It's really important that I communicate with every other provider who's taking care of that patient to make sure that together we don't accidentally give the child a toxic dose of local anesthetic. So I might be giving local anesthetic for my nerve block. If I'm not the primary anesthesiologist, they might be giving some lidocaine to intubate the patient. And then the surgeons, say I'm doing a block on a knee that doesn't completely cover the surgery and the surgeons want to inject some local too, they might be injecting local additionally. And so it's important that when we add all of these sources of local together, that together they're not a toxic dose. And there's a couple ways that you can add local together. What I recommend for the majority of people who don't have to do this math very often is to download an app like the Safe Local app that will do the math for you. So the Safe Local app was developed by some colleagues of mine at Johns Hopkins, and it allows you to just put in the local that you've given, and then it will do the math for you and tell you how much local is remaining available for kind of various different local anesthetic types. Personally, I do this math pretty often, and so I tend to do it by hand. And if you're doing it by hand, remember that it's not the milligrams of the different local that are additive, but it's rather the percent of the maximum dose that's additive. So if I were to give 60% of a maximum dose of ropivacaine, and the surgeons wanted to inject some bupivacaine at the end of the surgery, if I've given 60% of the max dose of ropivacaine, the surgeons can have 40% of the maximum dose of bupivacaine. So it's the percentage of each type of local that's additive together rather than the milligrams or the milliliters of the individual types. Once I've determined how much local the surgeons can have, I write that up on the whiteboard in the OR for all to see. And I also make sure that I include it in the surgical timeout so that everyone is aware and that we don't accidentally give the patient too much. So in summary, when I'm doing a nerve block on a pediatric patient, I still screen them for contraindications to regional anesthesia. I decide if I'm going to do my block awake versus asleep, and usually it's asleep. I choose my local anesthetic, typically 0.2% ropivacaine, and I add about a mic per kilo of clonidine to it to help it last longer. And then I pick my volume. If it's a plain block, about a half of a cc per kilo. If I'm targeting a specific nerve, about a quarter of a cc per kilo. I always do my blocks in plain if I can. I'm very careful to aspirate frequently to decrease the risk of LAST. And I'm very careful to communicate with everybody who's taking care of that patient to make sure that we don't accidentally give too much local altogether. So hopefully I've met my objectives today. I've talked about safety data for pediatric regional anesthesia and specifically the safety of performing blocks under general anesthesia. I've talked about some key differences in anatomy and pharmacology between particularly infants and our older patients. Talked about some of the unique considerations that I'm thinking about when I'm doing nerve blocks in children and given you a framework for how to pick an appropriate weight-based dose for various types of nerve blocks in pediatric patients. These are my references, and I would love to take some questions.
There were a couple that popped up on the chat box.
Let me pause the share and see if I can find the chat box, sorry. Oh, there's the chat, okay. Can I talk about the gray zone? So the first question I see is, can you comment on the gray zone of redosing a single shot coddle at the end of a 2 to 3 hour surgery? I definitely can comment about that. So most of us are dosing our coddles either with ropivacaine or bupivacaine. And so the half-life for those drugs is about 4 hours or so. So if 4 hours have passed from my initial dose, then I feel comfortable giving the patient about a half of that initial dose back again. If it's been only 3 hours, I feel comfortable giving them about 37.5% of the initial dose back again. And if it's been 2 hours, about a quarter of the initial dose back again. And below 2 hours, I don't ever redose coddles. So that's the strategy that I used when I was a fellow, when we were redosing coddles and also peripheral nerve catheters throughout long procedures. We would give At 4 hours, half of the initial bolus, we felt comfortable giving that back again. And if it had not been 4 hours, then for every hour short of 4 hours, we would reduce that half by 25%. So that means 37.5% at 3 hours, 25% at 2 hours, and then below 2 hours, it's not worth redosing typically. And then the second question, this is a really good question. Do you worry about removing an epidural catheter in a neonate who has a low dose heparin infusion to maintain umbilical catheter patency? Should the heparin be discontinued for any amount of time? Typically, the neonatologists are very careful to not go above a certain amount of heparin per kilo to not get not hemodynamic, anticoagulant effects from that heparin. So usually I don't worry so much about heparin for low dose heparin for line patency when I'm removing epidural catheters. So I tend to not require them to stop that heparin. I think I don't think it particularly increases my risk of hematoma, and it certainly is important for them to maintain the patency of their lines. So typically, no, I don't make them stop those very low dose, very slow heparin infusions for line patency.
Awesome. Thank you so much.
It's time for our the afternoon session, and this is sort of the time-honored OSA tradition of hazing residents. No, I'm just kidding, guys. It's pretty low key. This is actually a really fun part of our annual meeting where we're going to hear from 3 of our OHSU residents about interesting cases. And by now we all know that interesting is code for cases that none of us are glad we see routinely anymore. But our residents get such a good education at OHSU that they've got lots to choose from. So first up, we're going to have Dr. Eric Zhang. He's our current OSA resident representative. He joined us in DC for our legislative conference. He'll be joining us in New Orleans for the ASA conference. And he's just an all-around good guy to hang out with. And I think he's going to keep the pediatric theme going. So without further ado, Eric, I'll turn it over to you.
Hello, everybody. Can everyone hear me okay? Anybody? Going once?
I can hear you.
We can hear you.
Perfect. Awesome. Nice to see everybody. Thanks for having me. It is really nice being among such esteemed personnel as yourselves and speakers and practitioners. Now you get the lowly resident who's desperately trying to figure out how to share my screen with you. And I think we just got it. Everybody see that okay? I'm going to take the silence for a yes.
Eric, it's still loading,
Yeah.
so we can't see anything yet.
Oh, how about now?
Same thing, says still loading.
Talk momentarily. There it is.
What if I made it big?
That's not working.
Well, if you'll bear with me, we'll just look at a tinier screen because at least that works. And I don't want to take up too much of y'all's time clicking buttons. Is that okay with everybody?
Yeah, that looks great.
All right. So I'll get right into it. I've got a short and sweet case for you guys about pediatric sedation in the setting of a mediastinal mass. This is a case that Dr. Kathy Chen and I worked on together. And she's unfortunately not here today. But to give you some background about what had happened, this happened back in June of earlier this year. There was a 3-year-old patient around 13 kilos who was otherwise previously quite healthy. She came to the OHSU pediatric emergency room as a referral from an outpatient urgent care center. I think it was a Zoom care clinic. After her grandmother had originally brought her there, noting that she had a lump on her chest that was palpable, it was kind of firm feeling. And then she got some basic workup done at the outside urgent care center, showing a remarkable white blood cell count. All of her vitals were actually quite normal at the time. And then she got the following chest x-ray done. Quite kind of confusing wording here, but long story short, I don't think that they really knew what they were looking at here on this chest x-ray. So they just wrote unusual configuration of the left chest with very little visible, lung parenchyma, some rarefication of the peripheral aspect of lung architecture, acute or chronic underlying pneumothorax cannot be excluded, underlying mass or central lesion cannot be excluded, recommend tertiary referral for further evaluation. Which fortunately is exactly what they did. So they referred her to Dornbecker for further evaluation and treatment. And given the lump on her chest and the floridly high white blood cell count, and now possibly something going on in the thorax, high concern for some kind of acute like leukemia or lymphoma process. And again, just to reiterate, she was otherwise known to be quite healthy, born from my mother who had preeclampsia, but otherwise uncomplicated childhood. So on initial presentation to the Dornbecker ED, we did confirm that she did have that small bump on her chest. It was only seemed to be at the time a few centimeters in diameter. She also had a small mass on the left eyelid, the upper superior eyelid as well. She was breathing the entire time, totally actually fine on room air, like no tugging, no nasal flaring, no signs of increased work of breathing. She was actually kind of pretty chill kid, pretty happy, as long as the grandmother was there at her bedside. It was notable though on exam, could not get any left-sided breath sounds whatsoever. She also had another set of labs drawn, her white blood cell count. This time at Dornbecker was even higher, it was like in the 120s. So this was the chest x-ray that was shot at Dornbecker. So you'll see here, the read immediately, this was a resident read at the time, just said likely mediastinal mass with rightward shift of the airway. So immediately alarm bells were ringing. This kid was basically immediately sent to the PICU after this large mass was diagnosed with any at all evidence of tracheal compression or deviation. And again, I just want to reiterate, the entire time, kid was setting totally well on room air. In the PICU, they did give her 2 liters of nasal cannula just for good measure, but by all means, it didn't seem like it was even necessary. Given the high white blood cell count, she got a blood smear as well, showing all these blasts, the eye mass, the intrathoracic mass. Obviously, malignancy was high up on the differential in everyone's brain at this time. So she was going to need quite an extensive workup at this point, as well as some procedures. Getting her lined up was going to be a process. So then, of course, it became a question of, well, how are we going to anesthetize this 3-year-old to get her through some long scans, a formal ophthalmologic exam, getting a PICC line placed for lab draws, etc., getting an LP done, needing to rule out like CNS lymphoma, getting a Dobhoff placed, and of course, getting an echo. So that was a lot of different things that needed to get done. And so pretty much the approach that we took was we prioritized it, thinking that the CT chest was going to be probably the most important starting point, characterizing this mess, seeing if it actually had visible airway compression on a CT scan, finding out where it was would also give us some diagnostic and management clues. At this point, the PICU also started her on IV Solumedrol immediately to help control any tissue swelling. And so we did do the CT. The CT was quite uneventful. I'll just show you what they actually found. So this was a anteriorly positioned, left-sided, quite large mediastinal mass, and it was actually compressing some vasculature, as you can see here. And obviously there's some tracheal deviation. It's very obvious here. But fortunately, the patient remained completely hemodynamically stable. And again, didn't really have an oxygen requirement, which is quite in our favor. All the blood work, again, just showing some confirmed diagnosis that this was, at this point, we kind of knew this was a T-cell lymphoblastic leukemia lymphoma. She had some tumor lysis syndrome at this point from the Solumedrol that she'd been getting, so she was started on Kxalate, Respiricase, etc. And she got an echo at this point with showing a large mass and a left-sided pleural effusion. It was a tiny effusion, no signs of tamponade physiology, otherwise normal cardiac function. So far, everything is quite reassuring. But again, so how did we do anesthesia for this person who needed all these procedures? Well, fortunately, again, she didn't need oxygen. That was the number one sort of starting point in thinking about this. She was able to sat on room air before even the nasal cannula above 93% in any position. So part of the consideration of this was trying to find if she had any positions that she would desat in, that she would do better in, or have respiratory distress in, etc. She came in, was sitting up, upright in the bed, was doing fine, laid her down, still continued to breathe fine, left and right sides, all seemed okay. So we didn't need a particular rescue position, which sometimes is needed for these cases. So we had a good idea that in any position, she could probably maintain a spontaneous airway, which is reassuring. And the other thing was that, she was quite a cooperative patient to start, which is nice. Getting her to cooperate, at least with the setup of things, was quite easy. So as long as the grandmother was there, we quickly found out that that was the case. Of course, all the ASA monitors we needed, capnography, etc. All procedures were done in the ICU room that she came in, with anesthesia house staff there leading it, Kathy Chen, of course. ICU providers are also there, and of course, sedation nursing helped push all of the medicines that were given. So of course, we had emergency airway equipment available. Our fallback, sort of our planning in our brains was sort of, well, if there is sort of a intrasedation collapse of the airway, some things we would fall back on. One of them would be a rigid bronch to help stent the airway, and the other, of course, is a super fallback would be ECMO, but we're not thinking quite that far at that point, just because she was doing so well. So for the actual MRI, PICC line, all that stuff, she did really, really well. Fortunately, I was able to just lie supine for most of the procedures except the LP. We chose for our anesthetic agents ketamine and dexmedetomidine, and there's some literature to support this. But the intuitive thinking is that, well, dexmedetomidine, of course, unlike propofol, does help to minimize any respiratory depression, and that the ketamine would be not only an anesthetic agent and an analgesic agent, but also would help to offset some of that bradycardia you might see from the Precedex. Fortunately, very uneventful. She obstructed intermittently while lying supine during the CT scan, had some snoring, decided down to the high 80s, but that was the lowest that it got. Gave her a shoulder roll and then immediately was back at it, doing well. She did great, tolerated some local anesthesia. The lumbar puncture was rolled onto her side, continued to maintain a patent spontaneous airway just fine. So fortunately, in our favor, this case was really, like I said, short and sweet. It was uneventful. Nothing crazy needed to happen. We definitely did not need a rigid bronch or ECMO. And no presentation would be complete without some sort of inter-op documentation. This was unfortunately paper charting, as this was done at the bedside. So you'll see what we did was set her up on 2 liters of nasal cannula during the procedure, set her supine down, and then gave her some pushes at the beginning of Precedex and of ketamine, and then pretty much just ran a drip of Precedex all throughout and a tiny bit of ketamine. And that kept her very nice and comfortable during the entire case. Hemodynamics were very, very stable. And most importantly, of course, she breathed very well the whole time, maintained her sats the whole time. So just for my learning's sake, things that sort of became apparent to me during this case are that, well, one, mediastinal masses are scary in any patient, but they are particularly frightening and concerning in the pediatric population for a number of reasons that I had gathered in the literature and in my discussions with people. So one, they tend to more often be malignant in children, and that's largely due to the fact that lymphomas are exceedingly common in children. Lymphomas, I'll just connect this to point 3, also tend to be very anterior and centrally positioned, and that is the most threatening in terms of tracheal pathology. So on top of that, children have smaller intrathoracic volumes, so they have less reserve. And then on top of that, their structures, the trachea itself, and all of those little vascular structures that surround it, are all softer and more easily compressed. Furthermore, even though we had good CT imaging and diagnostic workup for this patient, it sometimes, just given their size and their habitus, is very hard to actually see on imaging true radiologic evidence of airway narrowing. So it can be hard to characterize just how risky this is. One kind of interesting figure that I had found in the literature was this chart that Hack et al. Had made, basically trying to stratify, this is in pediatric patients who were undergoing general anesthesia, what kind of risk profile they were at for having intraoperative airway complications, just based on these kinds of imaging findings. So they use something called a cross-sectional area of the trachea, or CSA, and basically we're able to stratify patients into a high, intermediate, or low risk. But again, this can be hard to do in patients, especially if they're very, very small. So in summary, GA for all these kinds of procedures is risky. We, fortunately didn't need to do GA for most of these, procedures. So local and sedation are obviously your friends. Maintaining spontaneous airway is definitely going to be your friend for these procedures. It can actually be done in a number of ways. We use Precedex and ketamine, although in the literature review that I found and all the retrospective analyses, there actually didn't seem to be a big difference in outcomes, even in the providers who chose propofol as the maintenance anesthetic agent, which I found was interesting. All in all, she did great. Was finally sent home, was discharged on home dexamethasone, got all of her procedures and lines done while she was in the hospital. And then she's just now following up with hematology at Ophtha Clinic. And I saw this about, I think it was like 6 or 7 weeks after she was discharged or so, that she had quote unquote marked improvement of the mediastinal disease. And I'm very happy to have witnessed all this go down. Otherwise, I've got some references, but I will be happy to chat with the group.
I'm not sure I can ask a question because I'm still having cold sweats thinking about this patient showing up on my list. I'm still too nervous to even ask a question about this patient. Did she ever need GA for anything during her hospital stay?
She did not, and we were really hoping that she wouldn't. Unfortunately, it did come true. She did not need GA.
No, that's good. All right. Well, thanks, Eric. That was awesome.
Thank you so much.
Nice work. All right. Next up, Dr. Lucas Mukel. And Lucas, you're the current chief, right?
That's correct.
You're in company. I think there's a few retired chief residents on this call. So you're in company who knows how challenging that job can be. I first met Lucas when I was a resident over at OHSU. He was a med student, and I always thought it was intimidating being around the OHSU med students because they're like way smart. But Lucas always did a great job. I enjoyed working with him over the years, and I can tell you that he also fishes, which isn't relevant to this talk, but it's important to me, so I have to mention it. Anyways, take it away.
Thanks very much. Yes, correct. Still a resident here at OHSU, hopefully coming toward the end of all of the training. Unfortunately, on my side, my intraoperative record is not quite as clean as Eric's was for his presentation. So bear with me overall. Present a case, flash pulmonary edema following routine methergin administration. This is a case that also happened in June during one of my many OB advanced excursions here at OHSU. So we'll move into this. No disclosures whatsoever for me, still working for nearly free. Objectives, just the things I kind of want to drive home for the presentation: understand the diagnosis, management, etiology of pulmonary edema, especially flash pulmonary edema. review the common urotonic use, contraindications, side effects of agents we use for management of postpartum hemorrhage. For the case, this was a 37-year-old female, G6P0, comes in at 37 weeks and change. Scheduled cesarean delivery. She had placenta previa, which was known prior to all of her arriving to the OHSU. Transverse lie, abdominal cerclage was also in place. Additional things for her history, Asherman syndrome, recurrent pregnancy loss, advanced maternal age, COVID back in May, A2-GDM, she was on NPH about 60 units, QHS, you can see that on the side there, had a prior postpartum hemorrhage following a dilation and curettage, and seizure disorder, which she was on zonisamide for, had not had a seizure at all in the last 8 years, I believe, so very well controlled. I've listed some of the other medications that she was on there, none of those super concerning. Of note, had multiple prior anesthetics for different reasons. All of them were reviewed and were not complicated and had received Methergin actually in the past following her dilation and curettage where she had some hemorrhage. Otherwise, all of those anesthetics were reviewed and uncomplicated. And so my plan was just to repeat what I had seen from before my case with her. Really nothing revealing on her physical exam or otherwise concerning about this patient's case. BMI was normal, reassuring airway exam, normal vitals, was not having any trouble in the pre-op area. She was very nervous. The patient has an oncology nursing background, very aware of all of the things that go along with our medical system, and had a lot of questions about who would be in the room and why they'd be in the room, and asked that I do as much as I could to introduce all of those people. She's very nervous about finally getting a pregnancy all the way to term and was noticeably uncomfortable being all the way at term and wanted to be done with her delivery. Nothing scary on the rest of her laboratory or otherwise workup studies, normal labs, platelets maybe slightly low at 180, but not anything that would be concerned about in terms of neuraxial anesthesia. Didn't have any prior echo, no chest x-ray to view, was completely asymptomatic from her prior COVID infection and had never been hospitalized or required any treatment for that at all. Intraoperative events, which I put together here to try and just collect things into a little bit shorter time frame, but essentially brought to the operating room, we placed a L3-4 spinal. We were able to achieve a T4 level bilaterally within a few minutes. Had started her on a phenylephrine infusion, which is very common for us whenever we have neuraxial for these patients. Skin incision without issue. By 9:30, we were done with hysterotomy, delivering the baby, delivering the placenta. And I started her oxytocin infusion, gave a 3-unit bolus to try and improve tone overall. Checked back in with the surgeons. They asked for and promptly received a second 3-unit bolus of oxytocin. Still didn't have great improvement given the prior history of postpartum hemorrhage, no contraindications to it. Delivered 0.2 milligram methyl ergotamine via IM injection. Around 9:40, shortly following that, was watching my monitors, noticed a slight widening of the QRS, maybe some tachycardia. I made a phone call over the Vocera to my OB attending anesthesiologist. She offered to come to the room, and essentially as she comes through the door, this patient became significantly hypertensive, 170s over 120s, still had the phenylephrine infusion running at that time. Shortly following that, the patient began to feel quite nauseated, had a slight cough. The phenylephrine infusion had been discontinued, and in talking with Dr. Corbett, my OB attending, we were noticing some slight desaturations, 93, 94% on 2 to 4 liters nasal cannula. Patient still reporting some nausea and some cough. We had her turned to the side, provided suction if she was able to bring anything up. And at that time, I asked the circulating nurse to remove both the patient's partner as well as the newborn to the resuscitation area, PACU, just so that we could turn our full attention to managing the patient. Her SpO2 continued to decline as I switched her from nasal cannula to 10-liter oxygen via face mask. However, she rotated to where I could see her. She had pretty substantial pink froth coming from bilateral nares, significant difficulty maintaining any sort of oxygen saturation that anyone had been comfortable with. And at that time, I looked over the drapes and conveyed the urgency of the situation to our surgical colleagues, asked that they close as expeditiously as possible, and let them know that we were going to switch to general anesthesia, secure the airway, and continue to support the patient overall. Given that our leading concern was for flash pulmonary edema, we did go ahead and deliver 40 milligrams furosemide just to get started on volume removal. I was lucky enough, versus Eric, to have the computer to take all of the vitals for myself. You can see here The early portion of the case fairly uneventful and unconcerning. The noticeable increase in heart rate, blood pressure following the methergin administration, cessation of the phenylephrine drip overall, and then improvement in our heart rate, blood pressure after we induced general anesthesia. Propofol a magical drug. And then finalization initially of the case. As I've shown you here, we called for the ICU admission. That was all confirmed. We were ready to go. The surgeons were in the middle of their closure when we were notified that the count was off. So we called for x-ray. They brought mobile to the room. We asked that they shoot a chest x-ray as well while they were there. We found that there was a retained lap pad. And given that the patient was reasonably stable, we were only struggling with oxygenation and ventilation at the time, but overall wasn't requiring a significant amount of hemodynamic support. We made the decision to move the patient back to the operating bed, reopened the incision, and went looking for the retained lap pad. Some data from the case: 1.7 of blood loss, 1 liter of endotracheal tube fluid suctioned from her oropharynx, as well as once I had placed the tube, and had well over 1 liter of urine. We continued to struggle with her pulmonary edema the longer we were in the operating room. At one point, we had loss of end tidal on our monitors, the gas analyzer, at which time I asked the surgeons to feel for femoral pulse while asking for a code to be called, and additionally asked for a shock call without a concern that we would have to place the patient on VA ECMO or VV ECMO, depending on what we found for an etiology. Luckily enough, they were able to find bilateral femoral pulses, and it was found that the sampling line and gas analyzer were all full of edema fluid. And so it was a mechanical failure. So once all of that was sorted out, patient never required chest compressions or conversion to any backup cardiopulmonary support other than the ventilation. Unfortunately, through that time, she did develop pretty substantial need for inotropic support. And by the time we finally got out of the OBOR, she was on epinephrine infusion. I was pushing small doses of epinephrine as well, just to maintain overall reasonable hemodynamics. This fall off in blood pressure and heart rate at the end is all just due to monitor issues. I promised the patient had a reasonable blood pressure as I was leaving the OR. She did continue to require increasing levels of support as I got her to the ICU. This is the chest x-ray obtained immediately intraoperative as we looked for the retained lap pad. You can see significant bilateral edema, large cardiac silhouette throughout. And early on, there was a TTE down in the surgical ICU noted for significantly reduced EF in the 30 to 35% range. Given her narrow pulse pressure, ongoing hypotension, hemodynamic requirements, patient got 2 units of REDS. There was another shock call just to see if this person would actually require VA ECMO, and ultimately was doing better on some inotropy there, was transferred to the cardiac ICU after there were no acute surgical concerns for her ongoing management. Ongoing diuresis. Eventually, you can see there was a PA catheter placed while she was in the cardiac ICU. Luckily enough, she was extubated post-op day 1, transferred to the ward shortly following that, early on post-op day 2. Was actually discharged home post-op day 5 on metoprolol. Last I had checked in with her chart, her EF has recovered to 65%. She's on some metoprolol and doing well as an outpatient. Pulmonary edema is actually quite rare, less than 0.1%, as you can see, overall incidence in pregnancy. Defined as this accumulation extravascular fluid in the lung parenchyma. Signs and symptoms: worsening dyspnea. You've got a lot of hypoxemia, and if you have time to get your stethoscope out, you probably could hear rales on auscultation. Maybe that S3 gallop or murmur, but I got to be honest, I didn't do any of those things. The cough and pink sputum, as well as the desaturation, was enough to convince me I needed help. So in terms of etiology, essentially broke this down to a cardiogenic problem versus the lungs themselves. So either you've got too much volume, the heart can't move things forward, your valves aren't helping you out, and you've got backup of fluid into the lungs, or just overall rhythm issue. Complete heart block, atrioventricular dysynchrony can certainly lead to backup of fluid into the lungs. If the problem happens to be in the lung itself, if you get injury to the parenchyma or loss of your endothelial epithelial capillary barrier, you're going to end up with the same issue. Or if for whatever reason you get elevated hydrostatic or reduced oncotic pressure, you can end up with backup fluid into the alveoli. Management: oxygenation, oxygenation, oxygenation. So you've got to make sure that we're supplying O2 to get across to the capillaries and the hemoglobin. Make sure you maintain perfusion. So some of the other guidelines recommend early initiation of inotropy. First line agent is dobutamine, and then reduce fluid if circulating volume is a big problem with diuresis. Our case in particular, as I mentioned, this patient developed this progressive dyspnea with cough, expectoration. She just continued to feel that she had something that she couldn't bring up, which was not nausea, which is what I had initially mistaken that for, and then developed pretty significant hypertension and tachycardia with ongoing hypoxemia. Additional differential you should consider when you're faced with this type of hemodynamic picture: pulmonary embolism, amniotic fluid embolism, potentially myocardial infarction, acute peripartum cardiomyopathy or worsening cardiomyopathy, and lastly, potentially coronary vasospasm leading to reduced ejection fraction, reduced pump function for you. Management, luckily enough, most of this is what we did. Supplemental oxygen, make sure you maintain suction, hemodynamic support, and diuresis. I have to say, one of the scariest airways I've ever been a part of. I've never had to leave the yank hour sitting in the posterior pharynx to continue to evacuate fluid. It actually wasn't fast enough, and the only way I found my way to the cords was the bubbles, stream of bubbles that were coming up from the lungs. So that was not exactly what I would consider a good time. Notification and communication with the surgical team. They expedited the closure. You can reflect and say maybe that asking them to expedite the closure resulted in an inaccurate count, which then had some other sequelae. But at the end of the day, making sure that the team knows how serious the nature of the problem is and what we're going to do next becomes critical. Preparation for higher level of support. As I mentioned, we called the surgical ICU, made sure the patient had a place to go, as well as thinking about activating our shock team and figuring out what type of elevated support a young, otherwise healthy patient might need in this situation. And then management of the room overall and ancillary personnel. I asked for and received help from the OB nursing staff that came and helped us set up the glide scope, having the patient's partner and the newborn transported to a different part of the hospital so that we could just focus on what we were doing. What were all pretty critical steps in making sure that we did well for this patient. And then disposition overall, making sure the patient has access to whatever specialty is going to be required for ongoing management. So we're lucky enough to have our heart failure team in-house, and so they were available for consult almost immediately. Uterotonics in general, as we're all aware, used in prevention, treatment, postpartum hemorrhage. First line agent used pretty much everywhere, oxytocin. Second line includes methylargonavine, carbaprost, misoprostol. In terms of contraindications, patient you don't want to use these in. You don't want to use the methergin if they've got a history of hypertension. It's now been added to our patient's allergy list. Carbaprost, the hemabate, that PGF2 alpha will give you pretty severe bronchoconstriction. You're going to watch that in your asthmatics. Misoprostol overall, with a high sensitivity to that drug, you'd want to avoid it, otherwise no direct contraindications. In terms of use, I'm quoting some data from a study that looked at, I think, a little over 300 hospitals in the US, 2 million deliveries. About 7% or somewhere between 5 and 10% overall required some second line uterotonic for control of postpartum hemorrhage. So not completely infrequent. And of course, the goal overall is to get the uterus to shrink back down, constrict all the blood vessels, and reduce your ongoing hemorrhage. Methylargonavine in general, or specifically, I should say, synthetic analog of the ergos. Smooth muscle contraction is primarily mediated through your serotonergic agonism. It does have some alpha-1 adrenergic activity as well, which can give you systemic vasoconstriction, high afterload, which isn't great if your heart isn't working well overall. Also, reports in the literature of coronary vasospasm, reports in the literature of causing worse systemic vascular constriction and pulmonary edema in patients with known or diagnosed Raynaud's phenomenon as well, thinking that they may just have a higher resting tone in the peripheral vasculature. In terms of administration, IM, PO, or IV takes a little while to come on, somewhere between 2 and 10 minutes, depending on how you administer. Peak plasma, half hour to an hour later, and it hangs around 2 to 3 hours for a half-life as well. Watch out in your patients with liver function issues. CYP3A4 is your metabolism pathway for the methergin. Overall utilization of methergin, I had said 5 to 10% of all, and the majority of those deliveries had received methergin as the second line uterotonic. Decreased postpartum hemorrhage related morbidity, however, when compared to carbaprost, so about a twofold reduction in the need for going for uterine or hypogastric artery ligation or proceeding toward hysterectomy for control of postpartum hemorrhage when compared to carbaprost. So certainly what I would consider an early second line agent for utilization for uncontrolled postpartum hemorrhage. Following up on our cases, I mentioned, got 0.2 milligram IM methylorgonidine after the oxytocin wasn't quite sufficient and had that phenylephrine infusion running. These two things combined and potentially some peripartum cardiomyopathy that we didn't know about certainly led to a high afterload and then clearly a flash pulmonary edema setting for her. The early echoes did mention potential reverse Takotsubo cardiomyopathy. Her basal segments of the heart were pretty akinetic or hypokinetic overall, while the apex was moving very well. As I mentioned, her EF has now recovered. She's being followed by the cardiology team as an outpatient. The greater issues for her actually is PTSD and stress around all of the intraoperative events. As I mentioned, nursing background. When I went to speak with her after she was extubated post-op day 2, she had a lot of questions about what had happened and why it had happened, but expressed a considerable amount of distress over being able to watch her blood pressure go up and see that her heart rate was increasing and wondering what was happening, but not being able to feel like she could communicate it, which was because she was effectively drowning during most of that time. So you can understand how that would be a pretty disconcerting situation for her overall, but continues to struggle with that as an outpatient. Some references if anyone's interested in the data that I put together here today in the presentation. Otherwise, thank you. Short list of the people that came and were helpful in all of this, and happy to take any questions if there are any.
Lucas, there was one question from the chat, and I had the same question, just in sort of terms of mechanics. Ed, you mentioned a shock call or shock team a couple of times. What is that at OHSU?
Yeah, shock call gets you essentially all the people that you'd want if as I say, the balloon's going up. So this will get you CT surgery, CVICU, VA ECMO, or whoever's on the ECMO team. And I believe that also includes maybe our virtual ICU, maybe the AOD. In general, it gets you all the people that you need right away if you think you're going to have to move to this type of higher level support. This is for external hospitals can call a shock consult to OHSU if you feel like somebody has reached the end of the inotropy you can do for them, or the diuresis you can do for whatever it is the problem. When you say we're going to have to move beyond what we can do with our system, you would want to initiate a shock call. And so we'll do that, in a situation exactly like this, where we've reached the end of what we thought we could do for hemodynamic support, and we're considering moving to mechanical circulatory support.
And you mentioned that AOD is on that list, so there is anesthesiologists are part of that team.
Sorry, I meant AOD in terms of like our administrator on duty that will med flow and coordinate where this all needs to go. It isn't always including an anesthesiologist. It's mostly your CVICU type attending, and then they're able to coordinate with your anesthesiology team if you need them in order to support what you're doing. Since we had 4 of us in the room, I didn't think we needed yet another anesthesiologist, but yeah, that's mostly the rest of what it consists of.
Cool. I don't have that at St. Charles. I guess I'm the shock team when I'm there, or any of us are. Yeah, great talk, Lucas. Any other questions for him? Great. So far, Eric convinced me to never take care of a kid again. Lucas has convinced me to never cover OB again. And so we'll move on to Dr. Tara Dewan, who maybe she might just seal the deal on. Maybe I'll go work at Starbucks after this one. And I haven't met Tara. I don't think we have met. So I think she's the only resident on this list that I haven't met, but I look forward to doing so soon. Because I haven't met her, I reached out to my moles at OHSU to find out more about her. And it sounds like she's already well on her way to becoming an academic powerhouse, working on publications as a resident. And you're also the resident representative on the anesthesiology component of the ACGME. Is that correct?
Hi, yes, that is correct. And thank you for the high praise. I don't know if I deserve all of that, but I'm really happy to be here and to share an interesting case.
You have a really large dog too, right?
Yes, I have a French Mastiff and she's 140 pounds.
It's
So
over
she's-
3 times the size of my dog.
I
All right,
see, yeah.
take it away.
All right, so let me just. Can everyone see this? Yes?
Not
No?
yet.
Okay, so you can see the poster?
I can't see it.
Okay, all right, let's see if I can. Okay, share screen, all right. How about now? Can everyone see this?
Yeah, that's great.
Okay, awesome. Yeah, so I wanted to talk about an interesting case that I had on call. This was in March of this year. So the title of this presentation, it's Perioperative Management of a Submental Hematoma in Setting of a Supratherapeutic INR and Subsequent Supraventricular Tachycardia. So the reason I wanted to present this case is not necessarily due to any kind of atypical presentation of pathology. It's just because we had multiple things happening simultaneously, and I really felt that this was one of those cases where our whole fund of knowledge as anesthesiologists really was put to use in one case. So just to give you a short background, so I want to present, or just to read over the case description to get started. This was a 73-year-old female, history of Tachy-Brady syndrome with a dual chamber pacemaker in place. Atrial fibrillation, she was on Coumadin, as well as coronary artery disease status quo cabbage, tricuspid valve annuloplasty, and CKD stage 3. She actually presented to the OHSU ER from an outside hospital with an expanding submental hematoma in setting of a supratherapeutic INR. It was found to be greater than 15. The etiology of the supratherapeutic INR at the time was still unknown, but since this was an impending airway emergency, we were called pretty much right away as soon as she got to the ER, and we were told to move her to the operating room with ENT involved as well as an emergent case. So but I did get a chance to look back at the chart and kind of piece together a story as to how this was all happening. So she actually presented with 1 day of sore throat, odynophagia, dysphagia, and progressive submental swelling. She actually didn't have anyone living with her, so I'm not sure if there was an element of dementia and like she took too much warfarin, which led to the supratherapeutic INR. That part is still unclear to me. But regardless, she had this presentation and a physical exam and imaging that revealed, just as we suspected, a rapidly expanding hematoma extending from the floor of mouth into the vallecula and the right arytenoid. So ENT surgery was consulted emergently. The plan was to intubate in the operating room, given her risk of hemorrhage with the supratherapeutic INR as well as airway collapse. So as she was rolling back, we actually gave her PCC preoperatively to hopefully rapidly correct this INR before manipulating the airway in any sense. While we were still working on getting her stable from an airway perspective, she had a stable SVT after we gave her glycopyrrolate as we were rolling back. Our initial plan with her was to do an awake fiber optic intubation, which is why we gave her glycopyrrolate to allow for easy passing of our scope. So when we got to the operating room, we saw this stable SVT. It was not responsive to vagal maneuvers, adenosine, beta blockers prior to intubation. However, the patient was hemodynamically stable otherwise. We had a blood pressure cuff on. We had no lines on her as she was pretty much rolled straight from the ER to the operating room. And since she was stable, we decided to proceed with our first task of the day, which was to secure an airway as she was starting to report trouble breathing. So we proceeded with obtaining a view with our fiber optic scope, and initially she was awake. And she was one of those patients who was very cooperative, so we actually did not end up giving any sedation at all. And the initial awake fiber optic view was quite reassuring. Then we made the decision to induce her first and then secure the airway within a sleep fiber optic, given that our first look was pretty, it was reassuring, and we felt that that was a better experience for the patient. We induced her with propofol, succinylcholine. We were actually able to intubate her fairly easily and secure the airway. But as we proceeded with the intubation, her stable SVT then became unstable, which led to a drop in blood pressure with the unstable SVT. And we actually had to perform a synchronized cardioversion in the operating room after the intubation as we were transporting her to the CVICU. So there were a couple of things that I wanted to talk about for discussion part of this. I understand that this was a pretty complicated case with a lot of different pathologies going on at the same time, but I wanted to talk through why we made the decisions that we made and why we felt like, we had to approach this in a fragmented fashion rather than dealing with all of the pathologies at the same time. So because this was an impending airway collapse, our first and foremost task that we took most seriously was to secure the airway. And this right here is the difficult airway algorithm, which I'm sure all of you are very familiar with, so I'm not going to spend time going over that. But we were thinking with my attending and I at the time, Dr. Benson and I were thinking about the best way to approach this airway. We had very little information about what the airway would actually look like. We had some imaging from the outside hospital that unfortunately wasn't transferred with the patient. We relied on our ENT colleagues to kind of give us a sense of what was going on. But since this was a rapidly progressive pathology, the hematoma was rapidly progressing as we were rolling out, we didn't actually know how involved or what her anatomy would look like. So based on that, we decided definitely not to DL her. Also with concerns for bleeding, given the supratherapeutic INR. And we decided to first just examine the airway with a awake fiber optic. And we opted for the sleep intubation, given that the hematoma wasn't, given that we had a good view with the awake and we just wanted to make this a less traumatic experience for the patient. We definitely didn't feel like sedation was a good option for her, just given her hemodynamics and her cardiac history at the time, and the fact that we were dealing with a stable SVT at the same time as trying to secure the airway. So we decided to just induce her with, it was 60 milligrams of propofol. We gave her some succinylcholine and just decided to intubate. So once we did that, then the second thing that we were dealing with at that time was the supratherapeutic tachycardia. We followed our ACLS, algorithms. We were stable at the time prior to intubation, so we decided to just take a look at it. We did treat her with labetalol, adenosine, the vagal maneuvers, like I mentioned. That didn't really seem to help at the time, but really, I think with the stimulation of the intubation, she became very unstable, and we decided to move on to a synchronized cardioversion before delivering her to the CVICU. So that was pretty much our whole, that was the case of the night, and definitely one of the most challenging cases that I've been part of. And I think I learned a lot from this case in terms of trying to prioritize, which pathology should I address first, and then what comes next. We were trying to, while we were doing all of our care in the operating room, we were also trying to have some kind of reversal for the anticoagulation. Given our supratherapeutic INR, there are many reasons for why she may have had the supratherapeutic INR, but I think the main reason for this patient was just an unintentional overdose. She wasn't on any other medications that might have interacted with warfarin to lead to supratherapeutic INR. I didn't see any changes in diet after reading for her notes from the outside ER as well as our own ER's evaluation, and she wasn't really found to have any metastatic liver disease. We had a couple options for rapid reversal, including vitamin K, FFP, PCC, and the costs actually vary between the different options. The cheapest one is vitamin K, but we found that that was not the best option for this patient, given that we were going to be manipulating the airway very soon, and we were concerned about bleeding and subsequent hemorrhage into the airway. Our other options were 4-factor PCC and FFP. We actually reversed her with PCC. which is arguably the most expensive option. But I think given that this patient was threatened with a collapsible airway, we felt that that was the best option for her at the time. Just as a follow-up, I did actually follow this patient for a couple months afterwards just to see what was going on, because it was intriguing to me, the whole presentation and how she, was found to have this life-threatening pathology it kind of abruptly. She actually was found to have an incidental pancreatic mass on an abdominal CT afterwards. And they got the CT because they had some elevated LFTs on the prior labs that they were going to follow up on. And she was actually subsequently diagnosed with a stage 1B pancreatic adenocarcinoma. I'm not completely convinced that the elevated LFTs were the sole reason for the supertherapeutic INR, but I think that and the unintentional overdose were probably the culprits that I would suspect are the etiology for her presentation that night. And the fact that she was living alone, I think she must have, there might have been a component of trauma as well. But this was a really interesting case, a great case to be involved in as a resident, just to see how all of these things are managed simultaneously, and also how we all can come together and, take care of a patient and have ongoing care in the ICU. So I'll take questions at this time. I can stop sharing my screen, I think.
It looks like a couple have come across the chat window.
Okay. I think I see one from Dr. Mitchell.
Yeah.
Yeah, why did we give adenosine pre-intubation when she had stable SVT? We did not give her adenosine pre-intubation. We actually just treated with vagal maneuvers and beta blockers. And I apologize if I misspoke. We had given her adenosine after we intubated and after her SVT had become an unstable SVT. Okay. Did that answer your question, Dr. Mitchell, before I move on to the next one? Okay, awesome. And then the second one was, how did you determine the hypotension from tachycardia, not from propofol induction? Yeah, so I think the way her pressures were pretty much at her baseline maps before the intubation. And then afterward, we usually expect our hemodynamics to, like our blood pressures to rise with the stimulation of an intubation as well as tachycardia. But in her case, once we intubated, like we did see the blood pressures rise, but the tachycardia worsened and we saw that there was a decrease in blood pressure with the tachycardia. So we sort of put that picture together as an unstable SVT rather than as a consequence of our induction drug. And did we have the pacemaker interrogated after the cardioversion? We actually, just to talk a little bit more about the pacemaker, we did make a call to our EP colleagues at the time, and we did talk about, how we were going to, in case of this progressed to a tracheostomy, if we weren't able to secure the airway with a fiber optic intubation. And they said that since this was an emergent case, that the likelihood of this interfering with the pacemaker itself was quite low. So they didn't actually have us put a magnet on the pacemaker or anything. And we did, I believe the CVICU team did reach out to our EP colleagues after we had, transferred care to have the pacemaker interrogated. But at the time, we didn't really, looking back at it, I think we should have thought about how the pacemaker could have affected this. But at the time, we just didn't really consider the pacemaker to be an involving factor in our care. We just proceeded straight to a synchronized cardioversion because we knew that this was an unstable SVT. Any other questions, concerns?
Well, thank you. Thanks for presenting that. you guys should all come over to Bend. You're welcome to come and visit the magic anesthesia land known as the Ambulatory Surgery Center. Although we can have adventures there too. Yeah, thanks to all our residents for providing some interesting and terrifying cases. I'll still do anesthesia tomorrow, but certainly those adventures can happen, but I'm glad they're not as often as they were in residency. The next thing on our agenda is we're going to hear from Sabrina Riggs. She has been our lobbyist for quite some time. She's going to give us a legislative update and tell us about all sorts of existential crises facing our specialty. It's sort of like the terrifying case presentation, but of lobbyists. Actually, I hopefully don't have that much that's going on that's too scary. But yeah, let's we'll end the conference with Sabrina. Oh, and before I do that, she would be mad at me if I didn't make a plug to donate to the PAC. So the OSA, we have two separate budgets. There's our OSA budget that handles everything like sending our delegation to ASA and the routine operations of our component society. And then a separate budget, which is our PAC, which is how similar to the ASA PAC and national anesthesia. That's how we maintain our voice in Salem. And Sabrina does an outstanding job of helping us use our PAC dollars as strategically as possible. And she and I and everybody at the OSA would greatly appreciate if you would consider donating to that PAC because that's how we maintain our seat at the table in Salem. So with that, I'll turn it over to Sabrina.
Thank you very much. And thank you for that PAC plug. I did just put the link into the chat if anyone would like to contribute online. It's pretty quick and easy to do so through our website. So good to see you all virtually. For those of you I haven't had the chance to meet yet, my name is Sabrina Riggs. I am your contract lobbyist, and I've been with this group since I think 2016 or 2017. That's my first year with you all. So I work at Dalton Advocacy. It's a contract lobby firm. I manage our healthcare portfolio at that firm. So I represent you guys, several specialty physician groups, some home health folks, EMS, and a handful of others. So I'm just all healthcare all the time at this point. I do our state level advocacy. So that means I'm in Salem at the state capitol, being your voice there, and then also at all the state agencies on all the regulatory work. So I'm doing a lot of work with Oregon OSHA, the Health Authority, the Bureau of Labor and Industries, the medical board, and they do sort of regular rulemaking, ongoing rulemaking, like with the COVID-19 rules and mask requirements from the Health Authority and Oregon OSHA. And then other rulemaking that results from bills that pass during the legislative session. So a recent example of that would be a bill to increase the pipeline of surgical techs through an apprenticeship program. And that rulemaking is happening both at the Health Authority and through the Bureau of Labor and Industry. So it's been a pretty interesting one to watch, especially with the workforce challenges being what they are in healthcare. I understand that I'm basically the last thing standing between you and the rest of your weekend, so I'm going to run through all this pretty quick. I think I'm just going to give you a quick overview of a couple of things that happened in 2022, and then we'll talk a little bit about some exciting things that are coming in 2023. But before I get into that, I do find that it's helpful to do a little bit of level setting, just so we're all sort of singing from the same sheet of music. So currently, and during the 2022 session, Democrats had a supermajority in both legislative chambers in Salem. So 37 Democrats in the House and then 18 in the Senate. We also had a Democratic governor, so Democrats all over the place in Salem. And then some other quick kind of 101 facts to just keep in the back of your mind is every other year we have a long session. So during the odd number of years, we're in Salem for 6 months. Having a legislative session, and then during the even numbered years, we're just there for 35 days. So, and I will say the state agencies are just sort of meeting and doing rulemaking all year, all the time. So in 2022, we had a short session, so just 35 days we were in the building. The nice thing about short sessions, I'll say, is that legislators are limited in the number of bills that they're able to introduce. So it's a much more focused agenda. But during that time, they still introduced 271 bills from 90 legislators, and 127 of those passed. I think can sometimes be sort of the perception that the state legislators and politicians in general do a lot of arguing and not a lot of other work, and they're not getting a lot done. But I will say, of the bills that passed, 90% plus are passed on a bipartisan vote. And then of that, a significant portion of those bills are even passed unanimously. So they do get a decent amount done. A few bills that passed that are of interest, I think, to this group: House Bill 4035 in the 2022 session passed, and that has to do with redetermination of Medicaid eligibility and the creation of a bridge program. So the background on this bill is that during the COVID-19 public health emergency at the federal level, so the federal declaration of that emergency, which is still ongoing, CMS ruled that states were allowed to keep their Medicaid enrollees on their state health plans without having to sort of continually redetermine if they're eligible, which is what is normally required. So what that means is that once someone came onto Medicaid during COVID, they were able to stay on, and they're still on Medicaid. Once that federal public health emergency ends, which folks are estimating could be the end of the year, but most likely the kind of rumor is having it that it'll probably be next spring, we will need to redetermine everybody on our Medicaid rolls to determine if they are still eligible or not. We have on average about 1.1 to 1.2 million people on Medicaid in Oregon during non-COVID times, and I think we've crept up to about 1.4 million. So there is a decent chunk of people that the folks over at the Health Authority think may lose their eligibility and may come off of Medicaid during this redetermination process. I think early estimates were that it was up to about 300,000. I think, more recently, they're thinking maybe a little bit fewer than that. But there's going to be this population that is currently on Medicaid and is still low income, but they're not low income enough to keep that Medicaid coverage. And that's a concern for state legislators. Oregon really prides itself in having a really high insured rate. I think we're close to 98% at this point, if not above that. And we want to, keep that progress and not see folks not qualify for insurance anymore. So during the 2022 session, as part of this redetermination sort of framework bill that they passed, they also passed a piece of that bill that had to do with the creation of a bridge program. So sort of like a basic health program for those folks who are low income but are no longer going to qualify for Medicaid. So that is being created through sort of a task force process, and there's going to be significant applications that go back between CMS and the Oregon Health Authority to sort of create this state-run program. We participated as OSA both in monitoring that legislation and the task force and providing comments there. We asked that your reimbursement rates for providers who are participating in that basic health plan platform be higher than the current Medicaid reimbursement rates, which we all know are quite low. That recommendation was included in the final report of the task force. So I think that is great news. And as that program is being formed and the applications are being sent in to CMS there, I think that's a very helpful to have in that. Another interesting bill, I'll say from 2022 that actually failed was one about increasing legislator pay. So legislators only make about $30,000 a year currently for their service that they provide to the state. Every once in a while, we see bills that are introduced to increase their pay, and they typically fail. We saw one this last session that would have increased their pay to something that was tied to the state median income, which would be about $63,000. That bill failed again. It's kind of a tough vote to, more than double your pay on the taxpayer dime right before an election season. But the reason I bring this bill up is because it had a pretty big impact. Its failing had a pretty big impact on the legislative body as a whole. So we saw three pretty strong younger legislators, including the current chair of the House Health Committee, retire, and they cited the really low pay as a big reason for their retirement and saying it just was not sustainable. And there was a lot of conversation around fairness and representation, and a lot of conversation about how the current system really kind of only works to be able to run for office and stay in office for a long time and be influential if you are independently wealthy or retired or in a position like that. And I think there's a drive to have a younger and more diverse legislative body. And I think that this topic of legislator pay is going to continue to come back, and we may actually see something passed in the next few years there. So those are just a handful of bills. Of course, a lot is happening on the regulatory side. As I mentioned, we do a lot of that work at Dalton Advocacy. Lots of work with Oregon OSA over the last couple of years on COVID-19 requirements. And then, of course, the health authorities got some rules around masking and vaccination in healthcare settings that we're tracking very closely. Moving on to maybe something a little bit more exciting about what's coming up in the 2023 session. So it is going to be a long session, headed into, we'll start in February and go, or in January, I'm sorry, and go through June. Before that, we're going to have some elections, which is very exciting. We're going to have a new governor. We've got a three-way race right now between three very qualified women, which is really exciting to see. I'm sure you've seen all of their ads, maybe too many of their ads, but pretty fascinating to watch. And some of the polling's been pretty interesting. The interesting thing about having this three-way race is they really only need about 35% of the vote to have a champion out of that race. So it's interesting to see what Betsy Johnson is doing to that as running as an independent. We've also got, of course, the new congressional seat, CD6, and then a bunch of new legislators. So about 50% of the legislators in the Capitol in 2023 are going to be new. They'll have been there for 2 years or less. And I will say just something to flag about those guys that have been there for 2 years, the more senior members at this point, those were COVID years. So the Capitol was closed down for those 2 years, and the public, including the lobby, was all accessing the process virtually. So these legislators, it's going to be a whole new experience for them on how to interact in the building. And it's just a very different lawmaking experience to be in the building versus virtual. So can't wait for that. It's a very steep learning curve. I think I talk a decent amount about this amount of turnover and what it means for us. And really what it means is building relationships and doing a lot of education. So I think that the amount of turnover at the legislature really hit home for me when I was looking at the House Health Committee, which was a 10-person committee in the 2022 session. Of that 10-person committee, we only have one person returning. So that really presents quite a bit of opportunity for that relationship building. And we've been doing a lot of that over the summer. John mentioned our PAC. That's one of the primary ways that we're able to build relationships with our legislators. We co-hosted a couple of fundraisers over the summer with the incoming chair of the House Health Committee, which is Representative Rob Nose. We have a great relationship with him. And then also a good fundraiser for the Clinicians Caucus, which is it's a newly formed group. We have 3 physicians who are in the legislature right now, a couple others who are running for office and will be members of the Clinician Caucus, some dentists who are running for office, an optometrist also. So I think, looking into 2023 and beyond, that Clinician Caucus could be a pretty strong voting bloc on healthcare issues, which is very helpful for this group, especially as long as it continues to be sort of physician-led. So we're really working hard to build relationships there and keep our relationships strong. I think a couple of topics that we'll start to talk about in 2023, unsurprisingly, I'm sure to you all, is there's going to be a lot of conversation on healthcare workforce. Probably you'll see a good amount of funding asks there. The hospitals had a pretty large funding ask in front of the emergency board. Just this last week, I think they got about $10 million out of that group to help fund some different workforce incentives that they have. We're definitely going to see some scope of practice bills come back in 2023. So every session, it feels like there's a mid-level provider group that comes to the legislature and says that they should be able to do more than what their current scope of practice is. We'll see that come back. I think the naturopaths are going to come back and ask for some payment parity. The optometrists would like to do surgery. The podiatrists are continuing to sort of creep up the leg and what they're able to operate on. So
that's always not very fun conversation to have in the health committees. It does get sort of ugly, but I think what's different this session is that there's going to be some bills introduced that would create an independent scope commission. And this is modeled on what other states do and see success. And essentially how it works is that this independent commission, which is comprised of providers and actual experts, will be the entity that looks at scope increase proposals and then makes a recommendation to the legislature or deciding body. And I think that a model like that would be much better than what we currently have, which is a bunch of non-physicians and citizen legislators with really not very much healthcare background, if they have one at all, making pretty significant decisions that have a big impact on patient safety. So we're hoping to see some success with that independent scope commission bill. The good news is the chair of the Senate Health Committee seems pretty excited about it. And so hopefully we can sort of keep that up. We're also looking at a couple of other bills that are, hoping to make your life easier. Healthcare interpreter reimbursement. We passed a bill in 2021 that requires healthcare interpreters to be used from an Oregon Health Authority registry, which I think is great, especially from an equity standpoint, using certified interpreters. However, the problem is that Medicaid will pay for those interpreters, but commercial insurance won't. So we'll look at passing a bill in 2023 requiring insurers to actually pay for that. So that way it's not coming off the backs of clinics. We're going to see a bunch of opioid legislation, I think, from Dr. Dexter, who's a physician legislator. And then I think we'll see there was an effort in the 22 session to make assault on hospital workers a higher level crime than it is right now, and expand some protections there. I think we'll see that be reintroduced. And then let's see, it looks like we have some questions. States that have similar boards to the Independent Commission: Nebraska, Texas, Connecticut, Vermont. I think there's a couple of others, but those are the ones off the top of my head. And they're typically they can be run through like the health authority, for example, is probably who would run the program and have that sort of panel of experts. And then other sort of 2023 things that we're focusing on, lots of PAC building. We have a sort of small PAC right now, and this is our #1 tool to build our relationships with legislators. So we really need to build that back up, and that's going to be, I think, a big mission of OSA over the next year. And then if any of the above interested you, or if you would like just an opportunity to come to Salem, see the building, meet your legislators, I would encourage you to participate in our lobby day on April 5th, 2023. So mark your calendars now, and we'll be sending out more communication as that date gets closer. And I can take questions because that's all I had for you today.
Sabrina, did you see the question in chat from John Evans?
I did not. Yes, Dr. Pham and Senator Steiner Hayward. We have, our PAC has supported both of these folks already, which is exciting. I think Dr. Pham will be a member of the Clinician Caucus, and Senator Steiner Hayward, I think, would really like to be Senate President, as she'll be going for that role, I think, in 2023. So our support there is hopefully helpful in those endeavors.
Can you hear me? This is Joanne Jennings. I have a couple of questions.
Yeah.
Okay, #1, who is looking for a health position by the name of Patterson? I was asked for some funding for Patterson, who's going to be either the chair of one of the health divisions in either the Senate or the House. Who is this?
Yeah, Senator Deb Patterson. She is a Salem area senator who is currently the chair of the Senate Health Committee. She's got a tough re-election campaign against Raquel Moore Green, who is a House member on the healthcare side. So she's doing, it doesn't surprise me that she's asking for money. She's doing a lot of fundraising right now. And I will just flag, she is one of the legislators who's really excited about this independent scope commission. Senator Patterson is.
Okay, that sounds great. My second question is, can you comment on the DeReamer and Jamie McLeod Skinner with regard to the issues of replacing our former legislator on the Hill?
yeah, that's been an interesting one to watch, especially with the Dreamers history with this, with our group. And, you know, obviously the McLeod Skinner upset of Kurt Schrader in the primary. So, you know, OSA doesn't give to federal candidates. There's a lot of additional paperwork that would be required for us to do that. So OSA is not getting involved in that race. I'm not sure if ASA is. Perhaps some of our ASA folks could chime in.
Kate, Rob, are you still here?
Yeah, I'm here.
You want to talk about it a little bit?
I missed the beginning of your question, Joanne. What was it?
My question is the issue between Dreamer and the ASA in the past, or OSA in the past, and the other person, Skinner.
I can't comment on McLeod Skinner. I don't know much about that race. I did talk to the ASA about the OSA's history with Sean Dreamer. Sean Dreamer is not running for office. He is an anesthesiologist who owns an anesthesia group and primarily employs CRNAs who practice independently in Oregon, independently with him as a supervisor, but one physician cannot supervise that many CRNAs very closely. His wife is who is running for office, and she reached out to the ASA asking for money. And I just informed Manny that in the past, when the OSA was lobbying to get anesthesia assistants or AAs credentialed in Oregon, he went to the State House and testified against the OSA sponsored or supported bill and helped kill that bill. So Dr. Dreamer has not participated in OSA initiatives ever, and could argue that he has, you know, worked against us. So I didn't encourage heavy support by the ASA in that race.
I can concur on that. I think it's important for the anesthesiologists in that group who are going to vote for one or the other to have that information just as a information for you to determine whether you're going to vote for one or the other. Thank you.
Thanks, Joanne, for bringing that up. Any other questions for Sabrina?
Sabrina, as you know, Medicaid does not pay anesthesiologists well. And so, you know, this initiative to keep Oregonians receiving essentially Medicaid benefits so that they don't lose their insurance. Has there been an estimated financial cost of how many of those patients, if they didn't have Medicaid, would then go out and buy private insurance and therefore maybe improve our payer mix versus they would just be uninsured and not help our, you know, reimbursement rates?
Yeah, that's a great question. I think that there's still some industry studies happening by the insurers right now, and that issue of low Medicaid reimbursement rates was top of mind definitely during the Bridge Program Task Force, and we're really glad to see their recommendation move forward that reimbursement rates for the Bridge Program be higher than Medicaid. I think it would have been nice to see a little more specificity on exactly what that means, but we'll be looking forward to that definitely. But I think that in general, I can say that the thought was these folks would just be, for the most part, just uninsured versus on a commercial carrier.
Thank you. And thank you for all that you do. I know you guys don't see and talk to Sabrina more than once or twice a year, but she is busting her hump on a daily basis for us. And she's desperately trying to get our issues heard by legislators, and her participation in PAC sponsored events is love it or hate it. That's the way that we get our voices heard. So I hope to see at least 10 new PAC donations come in this week. The link is in the chat. And I'm now shameless at this point in telling you all that you have to contribute.
I appreciate it. Thank you.
I wouldn't cross Kate Ropp, so I'd go ahead and donate.
I hear that expression a lot. I didn't know I was so scary.
All right, any thanks everybody for joining us. Before we wrap up, any questions, comments, general OSA stuff, anything we didn't address today before we let you all go and enjoy the rest of your Sunday? Oh, great. Thanks. Thanks everybody for joining us this meeting. For the speakers who are still on, thanks for participating. I thought our panel of speakers today was excellent. I certainly got a lot out of it, and I hope you guys did too.